Nutrition in gastroenterology. Diligent attention to patients' nutritional needs can have a major positive impact on medical outcomes. This is particularly true in GI and liver disease because many of these conditions, in addition to altering nutrient metabolism and requirements, are prone to interfere with ingestion and assimilation of nutrients. Nutritional management, however, often continues to be an inadequately or incorrectly addressed component of patient care. Inadequate or misdirected attention to nutritional issues is due, in part, to failure to distinguish patients who stand to benefit from nutritional care from those whose outcomes will not respond to nutritional intervention. The fact that many clinical trials have failed to demonstrate a benefit of nutritional support in hospitalized patients is often because such a distinction has not been made. The major aim of this chapter is to provide the scientific principles and practical tools necessary to recognize patients who will benefit from focused attention to their nutritional needs, and to provide the guidance necessary to develop a suitable nutritional plan for these individuals. Over or underfeeding a patient can be detrimental to clinical outcomes, so developing a nutritional plan most appropriately begins by determining the patient's estimated caloric and protein needs. Basic nutritional concepts. Energy stores. Endogenous energy stores are oxidized continuously for fuel. Triglyceride, TG, present in adipose tissue is the body's major fuel reserve and is critical for survival during periods of starvation, Table 5.1. The high energy density and hydrophobic nature of TGS make them a 5-fold better fuel per unit mass than glycogen. TGS liberate 9.3 kcal/g when oxidized and are stored compactly as oil inside the fat cell. In comparison, glycogen produces only 4.1 kcal/g on oxidation and is stored intracellularly as a gel, containing approximately 2 grams of water per gram of glycogen. Adipose tissue cannot provide fuel for certain tissues like bone marrow, erythrocytes, leukocytes, renal medulla, eye tissues, and peripheral nerves, which cannot oxidize lipids and require glucose for their energy supply. During endurance exercise, glycogen and TGS in muscle tissue provide an important source of fuel for working muscles. Energy metabolism. Energy is required continuously for normal organ function, maintenance of metabolic homeostasis, heat production, and performance of mechanical work. Daily total energy expenditure, T, has 3 components: resting energy expenditure, RE, 70% of T, the energy expenditure of physical activity, 20% of T, and the thermic effect of feeding, 10% of T, which is the temporary increase in energy expenditure that accompanies enteral ingestion or parenteral administration of nutrients. Although the latter 2 components of T should be considered when estimating caloric needs for ambulatory individuals, in acutely ill, hospitalized patients, the energy expended in physical activity is typically ignored and the energy expended in the thermic effect of feeding is built into the predictive equations that follow. Resting energy expenditure represents energy expenditure while a person lies quietly awake in an interprandial state. Under these conditions, about 1 kcal/kg body weight is consumed per hour in healthy adults. Energy requirements of specific tissues differ dramatically, Table 5.2. The liver, intestine, brain, kidneys, and heart constitute roughly 10% of total body weight but account for about 75% of Re. In contrast, skeletal muscle at rest consumes some 20% of Re, but represents approximately 40% of body weight. Adipose tissue consumes less than 5% of Re but usually accounts for greater than 20% of body weight. An accurate assessment of Re is best obtained by indirect calorimetry, in which in vivo energy expenditure is estimated by measuring carbon dioxide production and oxygen consumption while the subject is at rest. Although indirect calorimetry is considered a gold standard for determining Re, obtaining such a measurement is not always practical and, in most instances, is unnecessary. Instead, one of several empiric equations can be used to estimate resting energy requirements, Table 5.3. Point 1-4 The Harris-Benedict and Mifflin equations are designed for use in adults, whereas the WHO formulas includes equations for both children and adults. These equations are generally accurate in healthy subjects but are inaccurate, for example, in persons who are at extremes in weight because of anomalous body composition, and it is in these settings where determination by indirect calorimetry is useful. 5 In the setting of acute illness, the predictive equations are usually adequate, although it is necessary to insert correction factors of one type or another since inflammation and metabolic stress greatly influence energy expenditure. Protein energy malnutrition, PEM, and hypocaloric feeding without superimposed illness each decrease Re to values 10% to 15% below those expected for actual body size, whereas acute illness or trauma predictably increases energy expenditure. See later. Energy expenditure of physical activity. The effect of physical activity on energy expenditure depends on the intensity and duration of daily activities. Highly trained athletes can increase their T 10 to 20-fold during athletic events. The activity factors shown in Table 5.4, each expressed as a multiple of Re, can be used to estimate T in active patients. The energy expended during a particular physical activity is equal to Re per hour, times activity factor, times duration of activity in hours. T represents the summation of energy expended during all daily activities, including rest periods. Thermic effect of feeding, eating or infusing nutrients increases metabolic rate. Dietary protein causes the greatest stimulation of metabolic rate, followed by carbohydrate and then fat. A meal containing all these nutrients usually increases metabolic rate by 5% to 10% of ingested or infused calories. Recommended energy intake in hospitalized patients. In arriving at a nutritional plan for hospitalized patients, it is usually not necessary to obtain actual measurements of energy expenditure with a bedside indirect calorimeter. A number of simple formulas can be used instead and make up in practical value what they lack in accuracy. A few examples follow. Methods incorporating metabolic stress factors. Metabolic stress, i.e., any injury or illness that incites some degree of systemic inflammation, will increase the metabolic rate through a variety of mechanisms. See later. The increase in energy expenditure is roughly proportional to the magnitude of the stress. 6 Thus, the total daily energy requirement of an acutely ill patient can be estimated by multiplying the predicted Re, as determined by the Harris-Benedict or Hu equations, by a stress factor, T equals Re times stress factor. Table 5.5 delineates metabolic stress factors that accompany some common conditions and clinical scenarios in inpatients. Because the Mifflin equation was not designed to be used to estimate T with stress factors, it is not recommended in this context. In acutely ill hospitalized patients, it is not usually necessary to include an activity factor. An alternative and simple formula for adult inpatients, although accompanied by some further loss in accuracy, is 20 to 25 kcal/kg of actual body weight, ABW/day for unstressed or mildly stressed patients, 25 to 30 kcal/ABW/day for moderately stressed patients, 30 to 35 kcal/ABW/day for severely stressed patients. In using this formula, adjustments are necessary when the ABW is a misleading reflection of lean body mass. An adjusted ideal body weight, IBW, should be substituted for ABW in obese individuals who are more than 30% heavier than their IBW. Desirable body weights appear in Table 5.6. Using an adjusted IBW helps prevent an overestimation of energy requirements. 6 and is calculated as adjusted IBW equals IBW plus 0.5, ABW, IBW. Table 5.2 Resting energy requirements of various tissues in a 70 kg man. Tissue mass, energy consumed, tissue grams, percentage body weight, kcal/day, kcal/g, tissue/day, percentage. Re liver 1552.2, 445, 0.28, 19 GI tract 2003.0, 300, 0.15, 13 brain 1402.0, 420, 0.30, 18 kidneys 300, 0.4, 361.27, 15 heart 300, 0.4, 235, 0.80, 10 skeletal muscle 28,040.0, 400, 0.014, 18 adipose 15,021.0, 80, 0.0054. Re, resting energy expenditure. Table 5.1 Endogenous fuel stores in a 70 kg man tissue fuel source mass grams kilocalories adipose triglyceride 13,121,000 liver protein 301,200 glycogen 100 400 triglyceride 5,450 muscle protein 6,000 24,000 glycogen 400 1,600 triglyceride 252,250 blood glucose 312 triglyceride 437 free fatty acids 0.5554 Part 2 Nutrition in gastroenterology in patients with large artifactual increases in weight due to extracellular fluid retention, e.g., ascites, the IBW should be used to estimate energy requirements rather than the ABW method without a stress factor. The most accurate and extensively validated equation for predicting daily energy expenditure in ill patients is one that does not incorporate a stress factor. It does, however, require knowledge of the minute ventilation, so its use is restricted to patients on mechanical ventilation. Point 4 This formula, often referred to as the Penn state equation, is T equals, recalculated by Mifflin equation times 0.96, plus, T max times 167, plus, VE times 31, 6212 T max is the maximum temperature in Celsius over the past 24 hours, VE is expired minute ventilation in liters. Table 5.7 describes a simple alternative method for estimating total daily energy requirements in hospitalized patients. It is based on BMI 7. It lacks the extensive validation of the prior algorithm as well as some of its accuracy, but it does not require knowledge of minute ventilation, is straightforward, and consequently has some genuine utilitarian value. Common sense has to be applied when using an inexact means such as this to estimate energy expenditure in hospitalized individuals, because illness commonly interjects artifacts into these calculations, e.g., ascites, anasarca. Caloric delivery and avoidance of hyperglycemia. Over the past 2 decades, the trend has generally been toward a more conservative approach to caloric delivery in acutely ill patients. One reason for this conservatism is that acute illness and its management often exacerbate pre-existing diabetes or produce de novo glucose intolerance. As a result, hyperglycemia is a frequent consequence of enteral, and especially parenteral, nutrition. The issue seems to be particularly germane for ICU patients, in whom even modest hyperglycemia results in worse clinical outcomes, usually of an infectious nature. High-quality clinical trials in surgical ICU, PsyQ, 8 and medical ICU, MICU, 9 patients have found that morbidity is substantially and significantly reduced in those randomized to intensive insulin therapy who maintain serum glucose levels below 111 mg/dl, compared with those whose glucose values were maintained below 215 mg/dl. Mortality was also significantly lower among PsyQ patients randomized to receive tight glucose control, although in the MICU study, such reductions in mortality caused by tight glucose control were only realized in those who resided in the MICU greater than 3 days. Similarly, in a clinical trial of pediatric ICU patients, secondary infections, length of PICU stay, and mortality were all reduced by intensive age-specific glucose control. Point 10 These observations are almost certainly the clinical expression of the numerous mechanistic impairments that acute hyperglycemia produces in the innate immune system. Point 11 The clinical benefits of tight glucose control in the ICU, however, have not always been reproducible. 12 and come at the cost of more frequent hypoglycemic episodes. 8-10 12 So the issue of how tight glucose control should be remains controversial. Extremely tight control, with the target range of 81 to 108 mg/dl, produced a 13-fold greater risk of hypoglycemia and a significantly greater mortality in a large multi-center trial of ICU patients. 13 and is, therefore, excessive. A panel of experts recently recommended instituting protocols to keep blood sugar levels at 150 mg/dl or lower in ICU patients, preferably by use of a continuous infusion of insulin, with monitoring every 1 to 2 hours so that appropriate adjustments can be made and blood sugar values less than 70 mg/dl are avoided. 14 The results of a meta-analysis of 29 trials in critically ill patients recapitulate the previously observed discrepancies between PsyQ and MICU patients. 15 Overall, the relative risk of septicemia was reduced approximately 25% in those randomized to tight glucose control, although this salutary effect was largely attributable to the PsyQ patients, in whom reduction in septicemia was almost 50%. No benefit was observed in MICU patients, nor were differences in overall mortality evident in any of the categories of critically ill patients. The question of appropriate caloric delivery to critically ill overweight and obese patients who account for a burgeoning Table 5.3 commonly used formulas for calculating resting energy expenditure Harris-Benedict equation men-women 66 plus, 13.7 times W, plus, 5 times H, 6.8 times A, 665 plus, 9.6 times W, plus, 1.8 times H, 4.7 times A, Mifflin equation men-women, 10 times W, plus, 6.25 times H, 5 times A, plus 5, 10 times W, plus, 6.25 times H, 5 times A, 161 World Health Organization Formula H, year, male female 0 to 3. 3 to 10 10 to 18 18 to 30 30 to 60 greater than 60, 60.9 times W, 54, 22.7 times W, 495, 17.5 times W, plus 651, 15.3 times W, plus 679, 11.2 times W, plus 879, 13.5 times W, plus 987, 60.1 times W, 51, 22.5 times W, plus 499, 12.2 times W, plus 746, 14.7 times W, plus 996, 8.7 times W, plus 829, 10.5 times W, plus 596 calculated as kilocalories per day. A. Age in years, H. Height in centimeters, W. Weight in kilograms. Table 5.4 Relative thermic effect of various levels of physical activity. Activity level examples: activity factor resting 1.0 very light standing, driving, typing 1.1 to 2.0 light walking 2 to 3 miles/hr, shopping, light housekeeping 2.1 to 4.0 moderate walking 3 to 4 miles/hr, biking, gardening, scrubbing floors 4.1 to 6.0 heavy running, swimming, climbing, basketball 6.1 to 10.0 adapted from Alpersday, Stenson W.F., Beer D.M. Manual of Nutritional Therapeutics. Boston, Little, Brown, 1995. Table 5.5 Metabolic stress factors for estimating total energy expenditure in hospitalized patients. Injury or illness relative stress factor * second or third degree burns, 40% BSA 1.6 to 2.0 multiple trauma 1.5 to 1.7 second or third degree burns, 20% 40% BSA 1.4 to 1.5 severe infections 1.3 to 1.4 acute pancreatitis 1.1 to 1.2 second or third degree burns, 10% 20% BSA 1.2 to 1.4 long bone fracture 1.2 peritonitis 1.2 uncomplicated postoperative state 1.1 * A stress factor of 1.0 is assumed. For healthy controls. BSA, body surface area. From Sita T. Chen KY Measuring Energy Expenditure in Clinical Populations, Rewards and Challenges. Ewer J. Clin Nutr 2013, 67:43642. Chapter 5 Nutritional Principles and Assessment of the Gastroenterology Patient 55.5 Proportion of patients cared for in ICUs is a controversial issue at present. A popular nutritional approach to such patients is so-called hypocaloric feeding, in which only 60% to 70% of the estimated energy requirement, or 11 to 14 kcal/kg of ABW, is delivered in conjunction with 2 to 2.5 grams of protein/kg of IBW per day, the latter minimizing the risk of producing net protein catabolism and loss of lean body mass. The purported advantages of hypocaloric feeding include improved glycemic control and prevention of metabolic complications like hypercapnia and hypertriglyceridemia. Reduction in fat mass and weight is another consequence of hypocaloric feeding, but should never be a primary objective in feeding obese ICU patients. Systematic reviews that have examined the use of hypocaloric feeding in obese ICU patients, and which have examined important endpoints such as mortality, length of stay, duration of mechanical ventilation, and infectious complications have not yet been able to arrive at a consistent consensus either supporting net benefits or risks of hypocaloric, compared to normocaloric, nutrition support. 16 Thus, the matter remains an unsettled one. Proteins. 20 different amino acids, AAS, are commonly found in human proteins. Some AAS, histidine, isoleucine, leucine, lysine, methionine, phenylalanine, threonine, tryptophan, valine, and possibly arginine, are considered essential because their carbon skeletons cannot be synthesized by the body. Other AAS, glycine, alanine, serine, cysteine, tyrosine, glutamine, glutamic acid, asparagine, and aspartic acid, are non-essential in most circumstances because they can be made from endogenous precursors or essential AAS. In disease states and in preterm infants, intracellular and/or plasma concentrations of certain non-essential AAS are often very low and thought of as conditionally essential AAS. For many years, supplemental glutamine was included in TPN to compensate for cellular depletion of this AA during critical illness. However, rigorously conducted clinical trials have shown no benefit associated with administration of supplemental 4-glutamine. 17-19 In a randomized placebo-controlled multi-center, multinational trial of critically ill adults with multi-organ failure, glutamine supplementation was associated with an increase in mortality. 18 Evidently, repletion of a conditionally essential AA during acute illness does not necessarily convey a benefit. However, there continues to be interest in defining clinical scenarios in critical illness, e.g., premature infants, in which supplementation with conditionally essential AAS might improve clinical outcomes. 20 Arginine, cysteine, glycine, glutamine, proline, and tyrosine are AAS that fall into this category. The body of an average 75 kg man contains about 12 kg of protein. In contrast to fat and carbohydrate, there is no storage depot for protein, so excess intake is catabolized and the nitrogen component is excreted. Inadequate protein intake causes net nitrogen losses, and because no depot form of protein exists, there is an obligatory net loss of functioning protein. The U.S. recommended daily allowance, RDA, of protein has been established at 0.8 g/kg/day, which reflects a mean calculated requirement of 0.6 g/kg/day plus an added factor to take into account the biological variance in requirement observed in a healthy population. Intravenously administered AAS are as effective in maintaining nitrogen balance as oral protein of the same AA composition. Table 5.6 Desirable weight in relation to height for men and women 25 years or older men, medium frame women, medium frame weight, lb, weight, lb, height, foot/inches, range midpoint height, foot/inches, range midpoint 5'1" 113 to 124 118.548 93 to 104 98.55 to 116 to 128 122 49 95 to 107 101 53 119 to 131 125 410 98 to 110 104 54 122 to 134 100 128 411 101 to 113 107 55 125 to 138 131.550 104 to 116 110 56 129 to 142 135.551 107 to 119 113 57 133 to 147 145 to 110 to 123 116.558 137 to 151 144.53 113 to 127 125 9 141 to 155 148.54 117 to 132 124.5510 145 to 160 153.55 121 to 136 128.551 149 to 165 157 56 125 to 140 132.560 153 to 170 161.557 129 to 144 136.561 157 to 175 166.58 133 to 148 140.562 162 to 180 171.59 137 to 152 144.563 167 to 185 176.510 141 to 156 148.5 corrected to nude weights and heights by assuming 1-inch heel for men, 2-inch heel for women, an indoor clothing weight of 5 and 3 pounds for men and women, respectively. Data from Metropolitan Life Insurance Company. New height standards for men and women. Statistical Bulletin 1959, 40:1-4. Table 5.7 Estimated energy requirements for hospitalized patients based on body mass index, kg/m2, energy requirements, kcal/kg/day. Asterisk 1535 to 40 15 to 1930 to 35 20 to 29 20 to 25 greater than or equal to 30 15 to 20. The lower range within each body mass index, BMI, category should be considered in calculating energy requirements for insulin-resistant or critically ill patients to decrease the risk of hyperglycemia and infection associated with overfeeding. Asterisk these values are recommended for critically ill patients and all obese patients. Add 20% of the total calories when estimating energy requirements in non-critically ill patients. 56 Part 2 Nutrition in gastroenterology. An individual's protein requirement is affected by several factors, such as the amount of non-protein calories provided, overall energy requirements, protein quality, and the patient's nutritional status. Table 5.8. Protein requirements increase when calorie intake does not meet energy needs. The magnitude of this increase is directly proportional to the deficit in energy supply. Therefore, nitrogen balance reflects both protein intake and energy balance. Correcting a negative nitrogen balance can sometimes be achieved merely by increasing caloric delivery if the total amount of calories has been inadequate. As metabolic stress, and with it, metabolic rate, increases, nitrogen excretion increases proportionately. Quantitatively, the relationship is approximately 2 mg nitrogen, N/kcal of Re. In part, this increase is explained by the fact that in metabolic stress, a larger proportion of the total substrate oxidized for energy is from protein. This has two important implications for managing the nutritional needs of ill patients. The first is that illness, by increasing catabolism and metabolic rate, increases the absolute requirement for protein, see Table 5.8, and does so in a manner that is roughly proportional to the degree of stress. Second, because a greater proportion of energy substrate in acute illness comes from protein, nitrogen balance is more readily achieved if a larger proportion of the total calories are from protein. In healthy adults, as little as 10% of total calories have to come from protein to maintain health, whereas in the ill patient, nitrogen balance is achieved more easily if 15% to 25% of total calories are delivered as protein. Protein requirements are also determined by the adequacy of essential AAS in the protein source. Inadequate amounts of an essential AA result in inefficient uptake, so proteins of low biologic quality increase the protein requirement. In normal adults, approximately 15% to 20% of total protein requirements should be in the form of essential AAS. Additional proteins are needed to compensate for excess loss in specific patient populations, e.g., patients with burn injuries, open wounds, and protein-losing enteropathy or nephropathy. Delivering less protein than is needed is often a necessary compromise in patients with acute kidney failure who are not adequately dialyzed. In this situation, the rise in azotemia is directly proportional to protein delivery. Once adequate dialysis is available, protein delivery should be increased to the actual projected need, including additional protein to compensate for losses resulting from dialysis. See Table 5.8. Most patients with hepatic encephalopathy respond to simple pharmacologic measures and, therefore, do not require protein restriction. Those who do not respond may benefit from a modest protein restriction, 0.6 g/kg/day. Nitrogen balance. Nitrogen, N, balance is commonly used as a proxy measure of protein balance, i.e., whether the quantity of protein or AAS taken in is sufficient to prevent any net loss of protein. N balance is calculated as the difference between N intake and N losses in urine, stool, skin, and body fluids. In the clinical setting, it can be conveniently calculated as follows for adults: N balance equals grams of N administered as nutrition, urinary urea Ng+4, every 6.25 grams of administered protein, or AAS, contains approximately 1 gram of N. The additional 4 grams of N loss incorporated into the equation is intended to account for the insensible losses from the other sources listed, and because urinary urea N only accounts for approximately 80% of total urinary nitrogen. N balance is a suitable surrogate for protein balance, because roughly 98% of total body N is in protein, regardless of one's health. A positive N balance, i.e., intake loss, represents anabolism and a net increase in total body protein, whereas a negative N balance represents net protein catabolism. For example, a negative N balance of 1 g/day represents a 6.25 g/day loss of body protein, which is equivalent to a 30 g/day loss of hydrated lean tissue. In practice, N balance studies tend to be artificially positive because of overestimation of dietary N intake and underestimation of losses due to incomplete urine collections and unmeasured outputs. It is best to wait at least 4 days after a substantial change in protein delivery before N balance is determined, because a labile N pool exists, and this tends to dampen and retard changes that otherwise would be observed as a result of altered protein intake. Carbohydrates. Complete digestion of the principal dietary digestible carbohydrates starch, sucrose, and lactose generate monosaccharides, glucose, fructose, and galactose. In addition, 5 to 20 grams of indigestible carbohydrates, soluble and insoluble fibers, are typically consumed daily. All cells can generate energy, adenosine triphosphate ADP, by metabolizing glucose to 3 carbon compounds via glycolysis, or to carbon dioxide and water via glycolysis and the tricarboxylic acid, TCA, cycle. There is no absolute dietary requirement for carbohydrate. Glucose can be synthesized endogenously from either AAS or glycerol. Regardless, carbohydrate is an important fuel because of the interactions between carbohydrate and protein metabolism. Carbohydrate intake stimulates insulin secretion, which inhibits muscle protein breakdown, stimulates muscle protein synthesis, and decreases endogenous glucose production from AAS. In addition, glucose is the required or preferred fuel for red and white blood cells, the renal medulla, eye tissues, peripheral nerves, and the brain. However, once glucose requirements for these tissues are met, 150 g/day, the protein-sparing effects of carbohydrate and fat are similar. 21 Lipids. Lipids consist of TGS, sterols, and phospholipids. These compounds serve as sources of energy, precursors for steroid hormone, prostaglandin, thromboxane, and leukotriene E synthesis, structural components of cell membranes, and carriers of essential nutrients. Dietary lipids are composed mainly of TGS, which contain saturated and unsaturated long-chain fatty acids, FAS, of 16 to 18 carbons. Use of fat as a fuel requires hydrolysis of endogenous or exogenous TGS and cellular uptake of released FAS, see Chapter 102. Long-chain FAS are delivered across the outer and inner mitochondrial membranes by a carnitine-dependent transport system. Once inside the mitochondria, FAS are degraded by beta-oxidation to acetyl coenzyme A, CoA, which then enters the TCA cycle. Therefore, the ability to use fat as a fuel depends on normally functioning mitochondria. A decrease in the abundance or function of mitochondria associated with AGING22 or deconditioning favors the use of carbohydrate as fuel. 23 Table 5.8 Recommended daily protein intake. Clinical condition. Daily protein requirement, G/kg/IBW, normal 0.80, metabolic stress 1.0 to 1.6, hemodialysis 1.2 to 1.4, peritoneal dialysis 1.3 to 1.5. Additional protein requirements are needed to compensate for excess protein loss in specific patient populations, e.g., patients with burn injuries, open wounds, protein-losing enteropathy, or nephropathy. Lower protein intake may be necessary for patients with renal insufficiency not treated by dialysis and certain patients with liver disease and hepatic encephalopathy. IBW, ideal body weight. Chapter 5 Nutritional Principles and Assessment of the Gastroenterology Patient. 57 Essential fatty acids. 5 Humans lack the desaturase enzyme needed to produce the N3, double bond between carbons 3 and 4, and N6, double bond between carbons 6 and 7, Fa series. Linoleic acid, C18:2, N6, and linolenic acid, C18:3, N3, are essential Fas and, therefore, should constitute at least 2% and 0.5%, respectively, of the daily caloric intake to prevent a deficiency state. Before the advent of parenteral nutrition, essential fatty acid deficiency, EFAD, was only recognized in infants and manifested as a scaly rash with a specific alteration in the plasma Fa profile, see later. Adults were thought not to be susceptible to EFAD because of sufficient essential Fa stores in adipose tissue. However, an abnormal Fa profile in conjunction with a clinical syndrome of EFAD is now known to sometimes occur in adults with severe short bowel syndrome who are on long-term TPN that lacks parenteral lipids. 24 Adults who have moderate to severe fat malabsorption, fractional fat excretion 20%, from other causes and who are not TPN dependent also frequently display a biochemical profile of EFAD. 25 Although whether such a biochemical state carries adverse clinical consequences is unclear. Moreover, TPN lacking any source of fat may lead to EFAD in adults if no exogenous source of EFAs is available. The plasma pattern of EFAD may be observed as early as 10 days after glucose-based TPN is started and before the onset of any clinical features. In this situation, EFAD is probably due to the increase in plasma insulin concentrations caused by TPN, because insulin inhibits lipolysis and, therefore, the release of endogenous essential Fas. The biochemical diagnosis of EFAD is defined as an absolute and relative deficiency in the two EFAs in the plasma Fa profile. The full clinical EFAD syndrome includes alopecia, scaly dermatitis, capillary fragility, poor wound healing, increased susceptibility to infection, fatty liver, and growth retardation in infants and children. Major minerals are inorganic nutrients that are required in large, greater than 100 mg/day, quantities and are important for ionic equilibrium, water balance, and normal cell function. Malnutrition and nutritional repletion can have dramatic effects on major mineral balance. Evaluation of macromineral deficiency and the RDA of minerals for healthy adults are shown in Table 5.9. Micronutrients, vitamins and trace minerals, are a diverse array of dietary components that are necessary to sustain health. The physiologic roles of micronutrients are as varied as their composition. Some are used in enzymes as coenzymes or prosthetic groups, others as biochemical substrates or hormones. In some cases, their functions are not well defined. The average daily dietary intake for each micronutrient required to sustain normal physiologic operations is measured in milligrams or smaller quantities. In this way, micronutrients are distinguished from macronutrients, carbohydrates, fats, and proteins, and macrominerals, calcium, magnesium, and phosphorus. An individual's dietary requirement for any given micronutrient is determined by many factors, including its bioavailability, the amount needed to sustain its normal physiologic functions, a person's sex and age, any diseases or drugs that affect the nutrient's metabolism, and certain lifestyle habits like smoking and alcohol use. The U.S. National Academy of Sciences Food and Nutrition Board regularly updates dietary guidelines that define the quantity of each micronutrient that is adequate to meet the known nutrient needs of practically all healthy persons. These RDAs underwent revision between 1998 and 2001, and the values for adults appear in Tables 5.10 and 5.11. Formulating an RDA takes into account the biologic variability in the population, so RDAs are set 2 SDS above the mean requirement. This allows the requirements of 97% of the population to be met. Thus, ingestion of quantities that are somewhat less than the RDA are often sufficient to meet the needs of a particular individual. A tolerable upper limit, TUL, which is the maximal daily level of oral intake that is likely to pose no adverse health risks, has been established for most micronutrients. See Tables 5.10 and 5.11. Present recommendations for how much of each micronutrient is needed in individuals on TPN are based on far less data than were available for development of the RDAs. Nevertheless, it is important to have guidelines, and Table 5.12 provides such recommendations. Vitamins are categorized as fat-soluble, A, D, E, K, or water-soluble, all others, see Table 5.10. This categorization remains physiologically meaningful. None of the fat-soluble vitamins appear to serve as coenzymes, whereas almost all of the water-soluble vitamins appear to function in that role. Also, the absorption of fat-soluble vitamins is primarily through a micellar route, whereas the water-soluble vitamins are not absorbed in a lipophilic phase in the intestine, see Chapter 103. Trace minerals. Compelling evidence exists for the essential nature of 10 trace elements in humans: iron, zinc, copper, chromium, selenium, iodine, fluorine, manganese, molybdenum, and cobalt, see Table 5.11. The biochemical functions of trace elements have not been Table 5.9. Major mineral requirements and assessment of deficiency. Mineral enteral parenteral, MAL. Symptoms or signs of deficiency. Laboratory evaluation test. Comment: calcium 1000 to 1200 mg 5 to 15. Metabolic bone disease, tetany, arrhythmias. 24HR. Urinary calcium dual energy radiation absorptiometry. Reflex recent intake. Reflex bone calcium content. Magnesium 300 to 400 mg 5 to 15. Weakness, twitching, tetany, arrhythmias. Hypocalcemia. Serum magnesium. Urinary magnesium may not reflect body stores. Phosphorus 800 to 1200 mg 20 to 60. Weakness, fatigue, leukocyte and platelet dysfunction, hemolytic anemia, cardiac failure, decreased oxygenation. Plasma phosphorus may not reflect body stores. Potassium 2 to 5 grams 60 to 100. Weakness, paresthesias, arrhythmias. Serum potassium may not reflect body stores. Sodium 0.5 to 5 grams 60 to 150. Hypovolemia, weakness. Urinary sodium may not reflect body stores. Clinical evaluation is best. 58. Part 2. Nutrition in Gastroenterology. Table 5.10. Salient features of vitamins. Vitamin deficiency, RDA, *, toxicity, TUL. Assessment of status of follicular hyperkeratosis and night blindness are early indicators. Conjunctival xerosis, degeneration of the cornea, keratomalacia, and dedifferentiation of rapidly proliferating epithelia are later indications of deficiency. Bito spots, focal areas of the conjunctiva or cornea with foamy appearance, are an indication of xerosis. Blindness caused by corneal destruction and retinal dysfunction may ensue. Increased susceptibility to infection is also a consequence. 1 μg of retinol is equivalent to 3.33 IU of vitamin A, F, 700 μg, M, 900 μg. In adults, greater than 150,000 μg may cause acute toxicity, fatal intracranial hypertension, skin exfoliation, and hepatocellular injury. Chronic toxicity may occur with habitual daily intake of greater than 10,000 μg, alopecia, ataxia, bone and muscle pain, dermatitis, cheilitis, conjunctivitis, pseudotumor cerebri, hepatic fibrosis, hyperlipidemia, and hyperostosis are common. Single large doses of vitamin A, 30,000 μg, or habitual intake of greater than 4,500 μg/day during early pregnancy can be teratogenic. Excessive intake of carotenoids causes a benign condition characterized by yellowish discoloration of the skin, 3,000 μg. Retinol concentration in the plasma, as well as vitamin A concentrations in milk and tears, are reasonably accurate measures of status. Toxicity is best assessed by elevated levels of retinol esters in plasma. A quantitative measure of dark adaptation for night vision and electroretinography are useful functional tests. D-deficiency results in decreased mineralization of newly formed bone, a condition called rickets in childhood and osteomalacia in adults. Deficiency also contributes to osteoporosis in later life and is common following gastric bypass procedures. Expansion of epiphyseal growth plates and replacement of normal bone with unmineralized bone matrix are the cardinal features of rickets. The latter feature also characterizes osteomalacia. Deformity of bone and pathologic fractures result. Decreased serum concentrations of calcium and phosphate may occur. 1 μg is equivalent to 40 IU, 15 μg, ages 19 to 70, 20 μg, ages 70. Excess amounts result in abnormally high concentrations of calcium and phosphate in the serum. Metastatic calcifications, renal damage, and altered mentation may occur. 100 μg for ages greater than 9. Serum concentration of the major circulating metabolite, 25-hydroxyvitamin D, is an excellent indicator of systemic status except in advanced kidney disease, stages 4 to 5, in which impairment of renal 1-hydroxylation results in dissociation of the mono and dihydroxyvitamin concentrations. Measuring the serum concentration of 1,25-dihydroxyvitamin D is then necessary. E deficiency caused by dietary inadequacy is rare in developed countries. Usually seen in premature infants, individuals with fat malabsorption, and individuals with abetalipoproteinemia. RBC fragility occurs and can produce hemolytic anemia. Neuronal degeneration produces peripheral neuropathies, ophthalmoplegia, and destruction of the posterior columns of the spinal cord. Neurologic disease is frequently irreversible if deficiency is not corrected early enough. May contribute to hemolytic anemia and retrolental fibroplasia in premature infants. Has been reported to suppress cell-mediated immunity, 15 mg. Depressed levels of vitamin K-dependent procoagulants, potentiation of oral anticoagulants, and impaired leukocyte function have been reported. Doses of 800 mg/day have been reported to increase slightly the incidence of hemorrhagic stroke, 1000 mg. Plasma or serum concentration of alpha-tocopherol is used most commonly. Additional accuracy is obtained by expressing this value per mg of total plasma lipid. The RBC peroxide hemolysis test is not entirely specific but is a useful measure of the susceptibility of cell membranes to oxidation. K-deficiency syndrome is uncommon except in breastfed newborns, in whom it may cause hemorrhagic disease of the newborn. Adults who have fat malabsorption or are taking drugs that interfere with vitamin K metabolism, e.g., warfarin, phenytoin, broad-spectrum antibiotics, and individuals taking large doses of vitamin E and anticoagulant drugs. Excessive hemorrhage is the usual manifestation, F. 90 μg, M. 120 μg. Rapid 4-infusion of vitamin K1 has been associated with dyspnea, flushing, and cardiovascular collapse. This is likely related to the dispersing agents in the dissolution solvent. Supplementation may interfere with warfarin-based anticoagulation. Pregnant women taking large amounts of the provitamin menadione may deliver infants with hemolytic anemia, hyperbilirubinemia, and kernicterus, TUL not established. Prothrombin time is typically used as a measure of functional vitamin K status. It is neither sensitive nor specific for vitamin K deficiency. Determination of fasting plasma vitamin K is an accurate indicator. Undercarboxylate plasma prothrombin is also an accurate metric, but only for detecting the deficient state, and is less widely available. Chapter 5 Nutritional Principles and Assessment of the Gastroenterology Patient 59 Table 5.10 Salient Features of Vitamins Cont D Vitamin Thiamine, Vitamin B1, Deficiency, RDA, Asterisk Toxicity, TUL, Assessment of Status 5 Classic Deficiency Syndrome, beriberi, remains endemic in Asian populations consuming polished rice diet. Globally, alcoholism, chronic renal dialysis, and persistent nausea and vomiting after bariatric surgery are common precipitants. High carbohydrate intake increases the need for B1. Mild deficiency commonly produces irritability, fatigue, and headaches. More pronounced deficiency can produce peripheral neuropathy, cardiovascular and cerebral dysfunction. Cardiovascular involvement, wet beriberi, includes heart failure and low peripheral vascular resistance. Cerebral disease includes nystagmus, ophthalmoplegia, and ataxia, Wernicke encephalopathy, as well as hallucinations, impaired short-term memory, and confabulation, Korsakoff psychosis. Deficiency syndrome responds within 24 hr to parenteral thiamine but is partially or wholly irreversible after a certain stage, F. 1.1 mg, M. 1.2 mg. Excess intake is largely excreted in the urine, although parenteral doses of greater than 400 mg/day are reported to cause lethargy, ataxia, and reduced tone of the GI tract, TUL not established. The most effective measure of vitamin B1 status is the RBC transcatolase activity coefficient, which measures enzyme activity before and after addition of exogenous TPP. RBCs from a deficient individual express a substantial increase in enzyme activity with addition of TPP. Thiamine concentrations in the blood or urine are also measured. Riboflavin, vitamin B2, deficiency is usually seen in conjunction with deficiencies of other B vitamins. Isolated deficiency of riboflavin produces hyperemia and edema of nasopharyngeal mucosa, cheilosis, angular stomatitis, glossitis, seborrheic dermatitis, and normochromic, normocytic anemia, F. 1.1 mg, M. 1.3 mg. Toxicity has not been reported in humans, TUL not established. Most common method of assessment is determining the activity coefficient of glutathione reductase in RBCs. The test is invalid for individuals with glucose 6-phosphate dehydrogenase deficiency. Measurements of blood and urine concentrations are less desirable methods. Niacin, vitamin B3, pellagra is the classic deficiency syndrome and is often seen in populations in which corn is the major source of energy. Still endemic in parts of China, Africa, and India. Diarrhea, dementia, or associated symptoms of anxiety or insomnia, and a pigmented dermatitis that develops in sun-exposed areas are typical features. Glossitis, stomatitis, vaginitis, vertigo, and burning dysesthesias are early signs. Occasionally occurs in carcinoid syndrome, because tryptophan is diverted to other synthetic pathways, F. 14 mg, M. 16 mg. Human toxicity is known largely through studies examining hypolipidemic effects, includes flushing, hyperglycemia, hepatocellular injury, and hyperuricemia, 35 mg. Assessment of status is problematic, blood levels of the vitamin are not reliable. Measurement of urinary excretion of the niacin metabolites and methylnicotinamide and 2-pyridone are thought to be the most effective means of assessment. Pantothenic acid, vitamin B5, deficiency is rare, reported only as a result of feeding semisynthetic diets or consumption of an antagonist such as calcium homopantothenate, which has been used to treat Alzheimer's disease. Experimental isolated deficiency in humans produces fatigue, abdominal pain, and vomiting, insomnia, and paresthesias of the extremities, 5 mg. Diarrhea is reported to occur with doses exceeding 10 g/day, TUL not established. Whole blood and urine concentrations of pantothenic acid are indicators of status, serum levels are not thought to be accurate. Pyridoxine, vitamin B6, deficiency is usually seen in conjunction with other water-soluble vitamin deficiencies. Stomatitis, angular cheilosis, glossitis, irritability, depression, and confusion occur in moderate to severe depletion. Normochromic, normocytic anemia has been reported in severe deficiency. Abnormal EEGs and, in infants, convulsions also have been reported. Isoniazid, cycloserine, penicillamine, ethanol, and theophylline are drugs that can inhibit B6 metabolism. Ages 19 to 50, 1.3 mg, greater than 50 year, 1.5 mg for women, 1.7 mg for men. Chronic use with doses exceeding 200 mg/day, in adults, may cause peripheral neuropathies and photosensitivity, 100 mg. Many useful laboratory methods of assessment exist. Plasma or erythrocyte PLP levels are most common. Urinary excretion of xanthurenic acid after an oral tryptophan load or activity indices of RBC aminotransferases, ALT and AST, all are functional measures of B6-dependent enzyme activity. Biotin, vitamin B7, isolated deficiency is rare. Deficiency in humans has been produced experimentally by dietary inadequacy, prolonged administration of TPN that lacks the vitamin, and ingestion of large quantities of raw egg white, which contains avidin, a protein that binds biotin with such high affinity that it renders it biounavailable. Alterations in mental status, myalgias, hyperesthesias, and anorexia occur. Later, seborrheic dermatitis and alopecia develop. Biotin deficiency is usually accompanied by lactic acidosis and organic aciduria, 30 μg. Toxicity has not been reported in humans, with doses as high as 60 mg/day in children, TUL not established. Plasma and urine concentrations of biotin are diminished in the deficient state. Elevated urine concentrations of methyl citrate, 3-methylcrotonal glycine, and 3-hydroxyisovalerate are also observed in deficiency. Continued 60 Part 2 Nutrition in Gastroenterology Table 5.10 Salient features of vitamins Cont D vitamin deficiency, RDA, asterisk toxicity, TUL, assessment of status folate, vitamin B9, women of childbearing age are the most likely to develop deficiency. The classic deficiency syndrome is a megaloblastic anemia. Hematopoietic cells in the bone marrow become enlarged and have immature nuclei, reflecting ineffective DNA synthesis. The peripheral blood smear demonstrates macroovulocytes and polymorphonuclear leukocytes with an average of more than 3.5 nuclear lobes. Megaloblastic changes in other rapidly proliferating epithelia, e.g., oral mucosa, GI tract, produce glossitis and diarrhea, respectively. Sulfasalazine and diphenantoin inhibit absorption, predisposing to deficiency. Habitually low intake may increase the risk of colorectal cancer. 400 μg of dietary folate equivalent DFE, 1 μg folic acid equals 1 μg DFE, 1 μg food folate equals 0.6 μg DFE. Daily dosage 1000 μg may partially correct the anemia of B12 deficiency and therefore mask, and perhaps exacerbate, the associated neuropathy. Large doses are reported to lower seizure threshold in individuals prone to seizures. Parenteral administration is rarely reported to cause allergic phenomena from dispersion agents, 1000 μg. Serum folate levels reflect short-term folate balance, whereas RBC folate is a better reflection of tissue status. Serum homocysteine levels rise early in deficiency but are nonspecific because B12 or B6 deficiency, renal insufficiency, and older age may also cause elevations. Cobalamin, vitamin B12, dietary inadequacy is a rare cause of deficiency, except in strict vegetarians. The vast majority of cases of deficiency arise from loss of intestinal absorption, a result of pernicious anemia, pancreatic insufficiency, atrophic gastritis, SIBO, or ileal disease. Megaloblastic anemia and megaloblastic changes in other epithelia, see folate, are the result of sustained depletion. Demyelination of peripheral nerves, the posterior and lateral columns of the spinal cord, and nerves within the brain may occur. Altered mentation, depression, and psychoses occur. Hematologic and neurologic complications may occur independently. Folate supplementation in doses exceeding 1000 μg/day may partly correct the anemia, thereby masking, or perhaps exacerbating, the neuropathic complications, 2.4 μg. A few allergic reactions have been reported from crystalline B12 preparations and are probably due to impurities, not the vitamin, TUL not established. Serum or plasma concentrations are generally accurate. Subtle deficiency with neurologic complications is increasingly recognized among those greater than or equal to 60 years of age, and can best be established by concurrently measuring the concentration of plasma B12 and 1. Serum methylmalonic acid, MMA, or 2. holotranscobalamin 2, holo-TCII, because the latter are sensitive indicators of cellular deficiency. A low normal plasma B12 of 200 to 350 pg/ml, equals 148-258 mol/L, with an elevated MMA or decreased holo-TCII should be considered a state of deficiency. Ascorbic and dehydroascorbic acid, vitamin C, overt deficiency is uncommonly observed in developed countries. The classic deficiency syndrome is scurvy, characterized by fatigue, depression, and widespread abnormalities in connective tissues, e.g., inflamed gingivae, petechiae, perifollicular hemorrhages, impaired wound healing, coiled hairs, hyperkeratosis, and bleeding into body cavities. In infants, defects in ossification and bone growth may occur. Tobacco smoking lowers plasma and leukocyte vitamin C levels, F, 75 mg, M, 90 mg. The requirement for cigarette smokers is increased by 35 mg/day. Quantities exceeding 500 mg/day, in adults, sometimes cause nausea and diarrhea. Acidification of the urine with vitamin C supplementation, and the potential for enhanced oxalate synthesis, have raised concerns regarding nephrolithiasis, but this has yet to be demonstrated. Supplementation with vitamin C may interfere with laboratory tests based on redox potential, e.g., fecal occult blood testing, serum cholesterol, serum glucose. Withdrawal from chronic ingestion of high doses of vitamin C supplements should occur gradually over 1 month because accommodation does seem to occur, raising a concern for rebound scurvy, 2000 mg. Plasma ascorbic acid concentration reflects recent dietary intake, whereas leukocyte levels more closely reflect tissue stores. Plasma levels in women are 20% higher than in men for any given dietary intake. *RDA, recommended daily allowance, established for female, F, and male, M, adults by the U.S. Food and Nutrition Board, 1999 to 2001, updated in 2010 for vitamin D and calcium. In some cases, data are insufficient to establish an RDA, in which case the adequate intake, AI, established by the board is listed. TUL, tolerable upper level, established for adults by the U.S. Food and Nutrition Board, 1999 to 2001. EEG, electroencephalogram, PLP, pyridoxal 5-phosphate, RBC, red blood cell, TPP, thiamine pyrophosphate. Adapted from Goldman L., Ozzie LOD, R&W, ETL, editors. Cecil Textbook of Medicine. 23rd ed. Philadelphia, W. B. Saunders, 2014. With permission. Chapter 5 Nutritional Principles and Assessment of the Gastroenterology Patient 61 Table 5.11 Salient Features of Trace Minerals 5 Mineral Deficiency, RDA, *Toxicity, TUL, assessment of status chromium deficiency in humans is only described for patients on long-term TPN containing inadequate chromium. Hyperglycemia or impaired glucose tolerance is uniformly observed. Elevated plasma-free fatty acid concentrations, neuropathy, encephalopathy, and abnormalities in nitrogen metabolism are also reported. Whether supplemental chromium may improve glucose tolerance in mildly glucose intolerant but otherwise healthy individuals remains controversial. F. 25 μg, M. 35 μg. Toxicity after oral ingestion is uncommon and seems confined to gastric irritation. Airborne exposure may cause contact dermatitis, eczema, skin ulcers, and bronchogenic carcinoma, no toll established. Plasma or serum concentration of chromium is a crude indicator of chromium status. It appears to be meaningful when the value is markedly above or below the normal range. Copper dietary deficiency is rare. It has been observed in premature and low birth weight infants exclusively fed a cow's milk diet and in individuals on long-term TPN without copper. Clinical manifestations include depigmentation of skin and hair, neurologic disturbances, leukopenia, and hypochromic, microcytic anemia, skeletal abnormalities, and poor wound healing. The anemia arises from impaired uptake of iron and is, therefore, a secondary form of iron deficiency anemia. The Deficiency Syndrome, except the anemia and leukopenia, is also observed in Menkes disease, a rare inherited condition associated with impaired copper uptake, 900 μg. Acute copper toxicity has been described after excessive oral intake and with absorption of copper salts applied to burned skin. Milder manifestations include nausea, vomiting, epigastric pain, and diarrhea. Coma and hepatocellular injury may ensue in severe cases. Toxicity may be seen with doses as low as 70 μg/kg/day. Chronic toxicity is also described. Wilson disease is a rare inherited disease associated with abnormally low ceruloplasmin levels and accumulation of copper particularly in the liver and brain, eventually leading to damage of these two organs, 10 mg. Practical methods for detecting marginal deficiency are not available. Marked deficiency is reliably detected by diminished serum copper and ceruloplasmin concentrations, as well as low erythrocyte superoxide dismutase activity. Fluoride intake of 0.1 mg/day in infants and 0.5 mg/day in children is associated with an increased incidence of dental caries. Optimal intake in adults is between 1.5 and 4.0 mg/day, F. 3 mg, M. 4.0 mg. Acute ingestion of greater than 30 mg/kg body weight of fluoride is likely to cause death. Excessive chronic intake, 0.1 mg/kg/day, leads to mottling of the teeth, dental fluorosis, calcification of tendons and ligaments, and exostosis, and may increase brittleness of bones, 10 mg. Estimates of intake or clinical assessment are used because no reliable laboratory test exists. Iodine in the absence of supplementation, populations relying primarily on food from soils with low iodine content have endemic iodine deficiency. Maternal iodine deficiency leads to fetal deficiency, which produces spontaneous abortions, stillbirths, hypothyroidism, cretinism, and dwarfism. Rapid brain development continues through the second year, and permanent cognitive deficits may be induced by iodine deficiency during that period. In adults, compensatory hypertrophy of the thyroid, goiter, occurs, along with varying degrees of hypothyroidism, 150 μg. Large doses, greater than 2 mg/day in adults, may induce hypothyroidism by blocking thyroid hormone synthesis. Supplementation with greater than 100 μg/day to an individual who was formerly deficient occasionally induces hyperthyroidism, 1.1 mg. Urinary excretion of iodine is an effective laboratory means of assessment. The thyroid-stimulating hormone, TSH, level in the blood is an indirect, not entirely specific means of assessment. Iodine status of a population can be estimated by the prevalence of goiter. Iron, most common micronutrient deficiency in the world. Women of childbearing age constitute the highest risk group because of menstrual blood losses, pregnancy, and lactation. Hookworm infection is the most common cause worldwide. The classic deficiency syndrome is hypochromic microcytic anemia. Glossitis and koilonychia, spoon nails, are also observed. Easy fatigability often develops as an early symptom before appearance of anemia. In children, mild deficiency of insufficient severity to cause anemia is associated with behavioral disturbances and poor school performance. Postmenopausal F, 8 mg, M, 8 mg, premenopausal F, 18 mg. Iron overload typically occurs when habitual dietary intake is extremely high, intestinal absorption is excessive, repeated parenteral administration of iron occurs, or a combination of these factors exists. Excessive iron stores usually accumulate in reticuloendothelial tissues and cause little damage, hemosiderosis. If overload continues, iron will eventually begin to accumulate in tissues such as hepatic parenchyma, pancreas, heart, and synovium, damaging these tissues, hemochromatosis. Hereditary hemochromatosis arises as a result of homozygosity of a common recessive trait. Excessive intestinal absorption of iron is observed in homozygotes, 45 mg. Negative iron balance initially leads to depletion of iron stores in the bone marrow biopsy and the concentration of serum ferritin are accurate and early indicators of such depletion. As deficiency becomes more severe, serum iron, Si, decreases and total iron binding capacity, TIBC, increases, and iron saturation, equals Si/TIBC, of 16% suggests iron deficiency. Microcytosis, hypochromia, and anemia ensue in latter stages of the deficient state. Elevated levels of serum ferritin or an iron saturation 60% raises suspicion of iron overload, although systemic inflammation elevates serum ferritin level regardless of iron status. Manganese deficiency has not been conclusively demonstrated in humans. It is said to cause hypocholesterolemia, weight loss, hair and nail changes, dermatitis, and impaired synthesis of vitamin K-dependent proteins, F, 1.8 mg, M, 2.3 mg. Toxicity by oral ingestion is unknown in humans. Toxic inhalation causes hallucinations, other alterations in mentation, and extrapyramidal movement disorders, 11 mg. Until the deficiency syndrome is better defined, an appropriate measure of status will be difficult to develop. Continued 62 Part 2 Nutrition in gastroenterology as well characterized as those of the vitamins, but most of their functions appear to be as components of prosthetic groups or as cofactors for enzymes. Aside from iron, the trace mineral depletion clinicians are most likely to encounter is zinc deficiency. Zinc depletion is a particularly germane issue to the gastroenterologist, because the GI tract is a major site for zinc excretion. Chronically excessive losses of GI secretions, such as chronic diarrhea and IBD, is a known precipitant for zinc deficiency, and, in this setting, zinc requirements often increase several-fold. 26 Nevertheless, a biochemical diagnosis of zinc deficiency is problematic, as is true for many of the other essential trace minerals, because accurate laboratory assessment of zinc status is complicated by the very low concentrations of zinc in bodily fluids and tissues, a lack of correlation between serum and red blood cell levels of zinc with levels in the target tissues, and the reality that suitable functional tests have yet to be devised. Furthermore, it is well recognized that in acute illness a shift in zinc occurs from the serum compartment into the liver, further obscuring the diagnostic value of serum zinc levels. 27 Alkaline phosphatase is a zinc-dependent protein, and therefore serum activity of the enzyme has sometimes been proposed as a functional measure of zinc status. However, its predictive value is quite low and therefore is inadequate for assessing individuals in a clinical setting. It is often best to simply proceed with empiric zinc supplementation in patients whose clinical scenario puts them at high risk of zinc deficiency. Some reports have indicated that TPN solutions that deliver several-fold more manganese than what is recommended in Table 5.12 may lead to deposition of the mineral in the basal ganglia, with resulting extrapyramidal symptoms, seizures, or both. 28 Because the content of manganese varies widely in the different trace element mixtures available for TPN compounding, health professionals need to be mindful of this issue as protocols for TPN mixtures are developed. Physiologic and pathophysiologic factors affecting micronutrient requirements. Age and evolution of physiology continues throughout the life cycle, with an impact on the requirements of certain micronutrients with aging. Specific RDAs for older adults have now been developed. The mean vitamin B12 status of most populations, for example, declines significantly with older age, in large part because of the high prevalence of atrophic gastritis and its resultant impairment of protein-bound vitamin B12 absorption. 29 Some 10% to 15% of the older ambulatory population is thought to have significant vitamin B12 depletion because of this phenomenon, and neuropathic degeneration may occur in older individuals whose plasma vitamin B12 levels are in the low normal range. 150 to 300 pg/ml. Even in the absence of Table 5.11 salient features of trace minerals. Cont D mineral deficiency, RDA, toxicity, TOL, assessment of status. Molybdenum cases of human deficiency are extremely rare, caused by TPN lacking the element or by parenteral administration of sulfite. Reported to result in hyperoxypurinemia, hyporacemia, low urinary sulfate excretion, and CNS disturbances. 45 μg. Molybdenum has low toxicity. Occupational exposures and high dietary intake are linked to hyperuricemia and gout in epidemiologic studies. 2 mg. No effective clinically available assessment exists. Rare cases of deficiency are associated with hyporacemia, hypermethionemia, and low levels of urinary sulfate with elevated excretion of sulfite, xanthine, and hypoxanthine. Selenium deficiency is rare in North America but has been observed in individuals on long-term TPN lacking selenium. Such individuals have myalgias and/or cardiomyopathy. Populations in some regions of the world, most notably some parts of China, have marginal intake of selenium. It is in these regions of China that Keshan disease is endemic, a condition characterized by cardiomyopathy. Keshan disease can be prevented, but not treated, by selenium supplementation. 55 μg. Toxicity is associated with nausea, diarrhea, alterations in mental status, peripheral neuropathy, and loss of hair and nails. Such symptoms were observed in adults who inadvertently consumed between 27 and 2,400 mg, 400 μg. Erythrocyte glutathione peroxidase activity and plasma, or whole blood, selenium concentrations are the most commonly used methods of assessment. They are moderately accurate indicators of status. Zinc deficiency of zinc has its most profound effect on rapidly proliferating tissues. Mild deficiency causes growth retardation in children. More severe deficiency is associated with growth arrest, teratogenicity, hypogonadism, and infertility, dysgeusia, poor wound healing, diarrhea, dermatitis on the extremities and around orifices, glossitis, alopecia, corneal clouding, loss of dark adaptation, and behavioral changes. Impaired cellular immunity also is observed. Excessive loss of GI secretions, e.g., through chronic diarrhea or fistulas, may precipitate deficiency. Acrodermatitis enteropathica is a rare recessively inherited disease in which intestinal absorption of zinc is impaired. F. 8 mg, M. 11 mg. Acute zinc toxicity can usually be induced by ingestion of 200 mg of zinc in a single day, in adults. It is manifested by epigastric pain, nausea, vomiting, and diarrhea. Hypernia, diaphoresis, and weakness may follow inhalation of zinc fumes. Copper and zinc compete for intestinal absorption. Chronic ingestion of greater than 25 mg zinc/day may lead to copper deficiency. Chronic ingestion of greater than 150 mg/day has been reported to cause gastric erosions, low high-density lipoprotein cholesterol levels, and impaired cellular immunity. 40 mg. There are no accurate indicators of zinc status available for routine clinical use. Plasma, erythrocyte, and hair zinc concentrations are frequently misleading. Acute illness, in particular, is known to diminish plasma zinc levels, in part by inducing a shift of zinc out of the plasma compartment and into the liver. Functional tests that determine dark adaptation, taste acuity, and rate of wound healing lack specificity. * Recommended daily allowance, RDA, established for female, F, and male, M, adults by the U.S. Food and Nutrition Board, 1999 to 2001. In some cases, insufficient data exist to establish an RDA, in which case the adequate intake, AI, established by the board is listed. Tolerable upper level, TOL, established for adults by the U.S. Food and Nutrition Board, 1999 to 2001. Adapted from Goldman L., Ozzie LOD, Arendt W., ETL, editors. Cecil Textbook of Medicine. 22nd ed. Philadelphia, W. B. Saunders, 2004. With permission. Chapter 5 Nutritional Principles and Assessment of the Gastroenterology Patient 63 5 Hematologic Manifestations. For this reason, the use of sensitive indicators of cellular depletion of vitamin B12, e.g., serum methylmalonic acid levels in conjunction with serum levels of vitamin B12, are now recommended for diagnosis. 30 Some experts also suggest that older adults should consume a portion of their vitamin B12 requirement in the crystalline form, i.e., as a supplement, rather than relying only on the naturally occurring protein-bound forms found in food. Compared with younger adults, elders require greater quantities of vitamins B6 and D and calcium to maintain health, and these requirements are reflected in the new RDAs, see tables 5.10 and 5.11. Malabsorption and maldigestion. Both fat and water-soluble micronutrients are absorbed predominantly in the proximal small intestine, the only exception being vitamin B12, which is absorbed in the ileum. Diffuse mucosal diseases that affect the proximal portion of the GI tract are, therefore, likely to result in multiple deficiencies. Even in the absence of proximal small intestinal disease, however, extensive ileal disease (SIBO) and chronic cholestasis may interfere with the maintenance of adequate intraluminal conjugated bile acid concentrations and thereby may impair absorption of fat-soluble vitamins. Conditions that produce fat malabsorption are frequently associated with selective deficiencies of the fat-soluble vitamins. The early stages of many vitamin deficiencies are not apparent clinically and therefore may go undetected until progression of the deficiency has resulted in significant morbidity. This can be disastrous in conditions like spinocerebellar degeneration due to vitamin E deficiency, which often is irreversible. 31 Fat-soluble vitamin deficiencies are well-recognized complications of cystic fibrosis and congenital biliary atresia, in which fat malabsorption often is overt, but monitoring is also necessary in conditions associated with more subtle fat malabsorption, such as the latter stages of chronic cholestatic liver disease. 31 Restitution of vitamin deficiencies can sometimes be difficult when severe fat malabsorption is present, and initial correction may require parenteral administration. In severe fat malabsorption, chemically modified forms of vitamins D and E that largely bypass the need for the lipophilic phase of intestinal absorption are commercially available for oral use and can be helpful. The polyethylene glycol succinate form of vitamin E, Nutri-Sol, is very effective in patients with severe fat malabsorption who cannot absorb conventional alpha-tocopherol. 32 Similarly, hydroxylated forms of vitamin D, 1-hydroxyvitamin D hectorol and 1,25-dihydroxyvitamin D ricotrol, can be used in patients resistant to the more conventional forms of vitamin D. Monitoring of serum calcium levels is indicated in the first few weeks of therapy with hydroxylated forms of vitamin D. Because they are considerably more potent than vitamin D2 or D3, and risk of vitamin D toxicity exists. In contrast, water-miscible preparations of fat-soluble vitamins, in which a conventional form of vitamin AORE is dissolved in polysorbate 80, e.g., Aquasol E, Aquasol A, have not been proved to improve overall absorption. Maldigestion usually results from chronic pancreatic insufficiency, which, if untreated, frequently causes fat malabsorption and deficiencies of fat-soluble vitamins. Vitamin B12 malabsorption also can be demonstrated in this setting, but clinical vitamin B12 deficiency is rare unless other conditions known to diminish its absorption are also present, e.g., atrophic gastritis or chronic administration of PPIs. 33 Whether long-term administration of PPIs alone warrants occasional checks of vitamin B12 status is a matter of debate. 34 Regardless, malabsorption of vitamin B12 from atrophic gastritis or with PPIs is confined to dietary sources of vitamin B12. Small supplemental doses of crystalline vitamin B12 are absorbed readily in both cases. Histamine 2 receptor antagonists also inhibit protein-bound vitamin B12 absorption, although the effect generally is believed to be less potent than with the PPIs. 35 Many medications may adversely affect micronutrient status. The manner in which drug-nutrient interaction occurs varies. Some of the more common mechanisms are described in Table 5.13. A comprehensive discussion of drug-nutrient interactions is beyond the scope of this chapter, and the reader is referred to other references for a detailed discourse on this topic. 36 Starvation during periods of energy or protein deficit or both. An array of compensatory mechanisms serves to lessen the pathophysiologic impact of these deficiencies. These responses decrease the metabolic rate, maintain glucose homeostasis, conserve body nitrogen, and increase the uptake of adipose tissue TGS to meet energy needs. To appreciate how acute illness disrupts this compensatory scheme, it is first necessary to understand how the body adapts to starvation in the absence of underlying disease. Table 5.12 Guidelines for daily administration of parenteral micronutrients in adults and children. Micronutrient adults children fat-soluble vitamins A 1000 μg, equals 3300 IU, 700 μg D5 μg, equals 200 IU, 10 μg E 10 mg, equals 10 IU, 7 mg K 1 mg 200 μg water-soluble vitamin C 100 mg 80 mg B6 4 mg 1 mg B12 5 μg 1 μg biotin 60 μg 20 μg folate 400 μg 140 mg niacin 40 mg 17 mg pantothenic acid 15 mg 5 mg riboflavin 3.6 mg 1.4 mg thiamine 3 mg 1.2 mg trace elements chromium 10 to 15 μg 0.2 μg/kg/ day copper 0.5 to 1.5 mg 20 mg/kg/day iodine *iron 1 to 2 mg 1 mg/day manganese 0.1 mg 1 mg/kg/day molybdenum 15 mg 0.25 mg/kg/day selenium 100 mg 2 mg/kg/day zinc 2.5 to 4.0 mg 50 mg/kg/day * naturally occurring contamination of parenteral nutrition formulas appears to provide sufficient quantities of iodine. Adult vitamin guidelines adapted from American Society of Parenteral and Enteral Nutrition, ASPEN. Board of Directors and the Clinical Guidelines Task Force. Guidelines for the use of parenteral and enteral nutrition in adult and pediatric patients. J. Parente or Enteral Nutri 2002, 26:144. Children's Values adapted from Green H.L., Hambidge K.M., Chandler R., Tsung R.C. Guidelines for the use of vitamins, trace elements, calcium, magnesium, and phosphorus in infants and children receiving total parenteral nutrition. Report of the Subcommittee on Pediatric Parenteral Nutrient Requirements from the Committee on Clinical Practice Issues of the American Society for Clinical Nutrition. AMJ Clin Nutr 1988. 48:1324, MJ Clin Nutr 1989, 49:1332, and MJ Clin Nutr 1989, 50:560. 64 Part 2 Nutrition in Gastroenterology Table 5.13 Interactions of drugs on micronutrient status. Drug S. Nutrient mechanism S. Cholestyramine vitamin D, folate adsorbs nutrient, decreases absorption. Dextroamphetamine, fenfluramine, levodopa. Potentially all micronutrients induces anorexia. Isoniazid pyridoxine impairs uptake of vitamin B6. NSAIDs iron. GI blood loss. Penicillamine. Zinc increases renal excretion. PPIs vitamin B12 modest bacterial overgrowth, decreases gastric acid. Pepsin, impairs absorption. Sulfasalazine folate impairs absorption and inhibits folate-dependent enzymes from Goldman L., Ozzie LOD, Arendt W., et al., editors. Cecil Textbook of Medicine. 22nd ed. Philadelphia, W. B. Saunders, 2004. With permission. During the first 24 hours of fasting, the most readily available energy substrates, i.e., circulating glucose, Phos, and TGS, and liver and muscle glycogen, are used as fuel sources. The sum of energy provided by these stores in a 70 kg man, however, is only about 5,000 kJ, 1,200 kilocalories, and therefore is less than a full day's requirements. Hepatic glucose production and oxidation decrease, whereas whole body lipolysis increases, the latter providing additional Phos and ketone bodies. 37 Oxidation of Phos released from adipose tissue TGS accounts for about 65% of the energy consumed during the first 24 hours of fasting. During the first several days of starvation, obligate glucose-requiring tissues like the brain and blood cells, which collectively account for about 20% of total energy consumption, can use only glycolytic pathways to obtain energy. Because Phos cannot be converted to carbohydrate by these glycolytic tissues, they must use glucose or substrates that can be converted to glucose. Glucogenic AAS derived from skeletal muscle, chiefly alanine and glutamine, are a major source of substrate for this purpose. Approximately 15% of the Re is provided by oxidation of protein. 38 The relative contribution of gluconeogenesis to hepatic glucose production increases as the rate of hepatic glycogenolysis declines because the latter process becomes redundant. After 24 hours of fasting, only 15% of liver glycogen stores remain. During short-term starvation, 1 to 14 days, several adaptive responses appear that lessen the loss of lean mass. A decline in levels of plasma insulin, an increase in plasma epinephrine levels, and an increase in lipolytic sensitivity to catecholamines stimulate adipose tissue lipolysis. 39, 40 The increase in Pho delivery to the liver, in conjunction with an increase in the ratio of plasma glucagon to insulin concentrations, enhances the production of ketone bodies by the liver. A maximal rate of ketogenesis is reached by 3 days of starvation, and plasma ketone body concentration is increased 75-fold by 7 days. In contrast to Phos, ketone bodies can cross the blood-brain barrier and provide most of the brain's energy needs by 7 days of starvation. 41 The use of ketone bodies by the brain greatly diminishes glucose requirements and thus spares the need for muscle protein degradation to provide glucose precursors. If early protein breakdown rates were to continue throughout starvation, a potentially lethal amount of muscle protein would be catabolized in less than 3 weeks. Similarly, the heart, kidney, and skeletal muscle change their primary fuel substrate to Phos and ketone bodies. Other tissues like bone marrow, renal medulla, and peripheral nerves switch from full oxidation of glucose to anaerobic glycolysis, resulting in increased production of pyruvate and lactate. The latter two compounds can be converted back to glucose in the liver using energy derived from fat oxidation via the Cori cycle, and the resulting glucose is available for systemic consumption. This enables energy stored as fat to be used for glucose synthesis. Whole body glucose production decreases by greater than 50% during the first few days of fasting because of a marked reduction in hepatic glucose output. As fasting continues, conversion of glutamine to glucose in the kidney represents almost 50% of total glucose production. Energy is conserved by a decrease in physical activity secondary to fatigue and a roughly 10% reduction in Re resulting from increased conversion of active thyroid hormone to its inactive form and suppressed sympathetic nervous system activity. During long-term starvation, 14 to 60 days, maximal adaptation is reflected by a plateau in lipid, carbohydrate, and protein metabolism. The body relies almost entirely on adipose tissue for its fuel, providing greater than 90% of daily energy requirements. 42 Muscle protein breakdown decreases to less than 30 g/day, causing a marked decrease in urea nitrogen production and excretion. The decrease in osmotic load diminishes urine volume to 200 ml/day, thereby reducing fluid requirements. Total glucose production decreases to approximately 75 g/day, providing fuel for glycolytic tissues, 40 g/day, and the brain, 35 g/day, while maintaining a constant plasma glucose concentration. Energy expenditure decreases by 20% to 25% at 30 days of fasting and remains relatively constant thereafter despite continued starvation. The metabolic response to short and long-term starvation differs somewhat between lean and obese persons. Obesity is associated with a blunted increase in lipolysis and decrease in glucose production compared with that in lean persons. 44. In addition, protein breakdown and nitrogen losses are less in obese persons, thereby helping conserve muscle protein. 45 Events that mark the terminal phase of starvation have been studied chiefly in laboratory animals. Body fat mass, muscle protein, and the sizes of most organs are markedly decreased. The weight and protein content of the brain, however, remain relatively stable. During the final phase of starvation, body fat stores reach a critical level, energy derived from body fat decreases, and muscle protein catabolism is accelerated. Death commonly occurs when there is a 30% to 50% loss of skeletal muscle protein. 46 In humans, it has been proposed that there are certain thresholds beyond which lethality is inevitable: depletion of total body protein between 30% and 50% and of fat stores between 70% and 95%, or reduction of BMI below 13 kg/m2 for men and 11 kg/m2 for women. 48 Malnutrition. In the broadest sense, malnutrition implies a sustained imbalance between nutrient availability and nutrient requirements. This imbalance results in a pathophysiologic state in which intermediary metabolism, organ function, and body composition are variously altered. Sustained is an important element of this definition, because homeostatic mechanisms and nutrient reserves are usually adequate to compensate for any short-term imbalance. Customarily, the term malnutrition is used to describe a state of inadequacy in protein, calories, or both, and is more precisely called protein energy malnutrition or protein calorie malnutrition. Occasionally it is used to describe a state of excessive availability, such as a sustained excess of calories, e.g., obesity, or a vitamin, e.g., vitamin toxicity. Chapter 5 Nutritional Principles and Assessment of the Gastroenterology Patient. 65 Protein Energy Malnutrition, PEM. 5 There are different pathways whereby PEM may evolve. Primary PEM is caused by inadequate intake of protein, calories, or both, or, less commonly, when the protein ingested is of such poor quality that one or more essential AAS becomes a limiting factor in the maintenance of normal protein metabolism. Secondary PEM is caused by illness or injury. Acute illnesses and injuries increase bodily requirements for protein and energy substrate and impair digestion, absorption, and uptake of these nutrients in various ways. Consequently, secondary PEM usually arises from multiple factors. Illness and injury also commonly induce anorexia, see later for mechanisms, so primary and secondary factors often act in concert to create PEM in the setting of illness. Illness or injury may directly interfere with nutrient assimilation. For example, extensive ileal disease or resection may directly produce fat malabsorption and a caloric deficit. The most common causes of secondary PEM, however, are the remarkable increases in protein catabolism and energy expenditure that occur as a result of a systemic inflammatory response. Re may increase as much as 80% above basal levels in a manner roughly proportional to the magnitude of the inflammatory response, which in turn is roughly proportional to the severity and acuity of the illness. Thus, Re in patients with extensive second and third degree burns, the prototype for maximal physiologic stress, may approach twice normal. With sepsis, Re is about 1.5 times normal, and with a localized infection or fracture of a long bone, Re is 25% above normal. 6 Such stress factors can be used to construct a formula for predicting the caloric needs of ill individuals, see Table 5.5. Protein catabolism during illness or injury also increases in proportion to the severity and acuity of the insult and therefore parallels the increase in energy consumption. The magnitude of increase in protein catabolism, however, is proportionately greater than that observed with energy consumption, such that urinary urea N losses, which reflect the degree of protein catabolism in acute illness, are about 2.5 times the basal level with maximal stress 0.6. This increase in catabolism results in a net loss of protein because the rate of synthesis usually does not rise in concert with the rise in catabolism. 49 No known storage form of protein exists in the body. So any net loss of protein represents a loss of functionally active tissue. A healthy adult typically loses about 12 grams N/day in urine, and excretion may increase to as much as 30 g/day during critical illness. Because 1 gram of urinary N represents the catabolism of approximately 30 grams of lean mass, it follows that severe illness may produce a daily loss of up to about 0.5 kilograms of lean mass as a result of excess protein catabolism. Most of this loss comes from skeletal muscle, where the efflux of AAS increases 2 to 6-fold in critically ill patients. 50 Mobilization of AAS from skeletal muscle appears to be an adaptive response. Once liberated, these AAS, in part, are deamined and used for gluconeogenesis. They are also taken up by the liver and other visceral organs. The proteolysis of muscle under stress thus enables the body to shift AAS from skeletal muscle, the somatic protein compartment, to the visceral organs, the visceral protein compartment, the functions of which are more critical for immediate survival during illness. Nevertheless, with sustained stress, the limitations of this adaptive response become evident, and even the visceral protein compartment sustains a contraction in mass. 42 Primary versus secondary protein energy malnutrition. A body compartment perspective. The type of tissue lost as malnutrition evolves is critical in determining the pathologic ramifications of weight loss. Over 95% of energy expenditure resides in the lean body mass, which, therefore, contains the bulk of metabolism that sustains homeostasis. It is the maintenance of this body compartment that is most critical for health. Lean body mass can be subdivided further into somatic and visceral protein compartments, blood and bone cells, and extracellular lean mass, such as plasma and bone matrix, Fig. 5.1. In total or semi-starvation in otherwise healthy individuals, adipose tissue predominates as a primary energy source, thus, fat mass contracts to a much greater degree proportional to the loss of lean mass. 42 Alterations in metabolism from injury or illness, however, produce a proportionately greater loss of muscle mass such that it matches or exceeds the loss in fat mass. 51 Although the lean mass lost in illness is preferentially from the somatic protein compartment, with sustained stress, there also will be a significant contraction of the visceral protein compartment, Table 5.14. The metabolic forces associated with acute illness and injury are potent, and restoration of muscle mass is unlikely with nutritional support unless the underlying inflammatory condition is corrected. There is increasing interest in attenuating or reversing net catabolism with the use of exogenous anabolic agents in conjunction with nutrition, although, to date, it remains unclear whether administration of beta-hydroxymethylbutyrate, growth hormone, oxandrolone, propranolol, or other anabolic agents in acute illness, improve clinical outcomes and outweigh their potential side effects. 52 Another important ramification of the potency of the catabolic state associated with acute illness is that most of the weight gained with provision of nutritional support is the result of increases in fat mass and body water. Only minor increases in lean mass are observed until the inflammatory focus is resolved. 53 Visceral mass 7%, muscle mass 22%, fat mass 28%, extracellular lean mass, plasma, bone mineral, etc. 36% blood cells, bone cells, etc. 7% Fig. 5.1 Body composition analysis by weight in a healthy adult. Speckled segments and gray segment collectively represent lean body mass. Speckled segments alone represent body cell mass. Adapted from Mason J.B. Gastrointestinal Cancer, Nutritional Support. In, Kelson D., Daly J., Kern S., et.al., Editors. Principles and Practice of Gastrointestinal Oncology. Philadelphia, Lippincott Williams and Wilkins, 2002. Table 5.14 Body compartment wasting and losses in simple starvation versus metabolic stress parameter. Skeletal muscle wasting, visceral wasting, loss of fat mass, starvation ++/* *+++ metabolic stress ++/* *+++ relatively spared early in the process, can become pronounced with extended starvation or metabolic stress. 66 Part 2 Nutrition. In gastroenterology, cytokines are the most important mediators of alterations in energy and protein metabolism that accompany illness and injury. In a wide spectrum of systemic illnesses, increased secretion of interleukin, IL-1 beta, tumor necrosis factor alpha, IL-6, and interferon gamma has been observed to be associated with increased energy expenditure and protein catabolism, as well as the shift of AAS into the visceral compartments. 54-56 Such observations concur with in vitro studies in human cells and animal models that have shown remarkably potent effects of these cytokines. Table 5.15. In the wasting syndrome associated with cancer, proteolysis-inducing factor and zinc alpha-2 glycoprotein, lipid mobilizing factor, are humoral mediators that appear to be unique to cancer cachexia, contributing to protein catabolism and loss of adipose tissue, respectively. 57 Promising data in animal models of cancer cachexia indicate that specific inhibitors of cancer-mediated protein catabolism can be designed that greatly reduce the morbidity and mortality associated with the cachexia produced by this disease. 58 Protein energy malnutrition in children. Undernutrition in children differs from that in adults because it affects growth and development. Much of our understanding of undernutrition in children comes from observations made in underdeveloped nations where poverty, inadequate food supply, and unsanitary conditions lead to a high prevalence of PEM. The Waterloo classification of malnutrition, Table 5.16, takes into account a child's weight for height, the inadequacy of which is termed wasting, and height for age, the inadequacy of which is termed stunting. 59 The characteristics of the three major clinical PEM syndromes in children, kwashiorkor, marasmus, and nutritional dwarfism, are outlined in Table May 17, 60. Although these three syndromes are classified separately, in reality, clinical presentations in which they overlap often occur. Kwashiorkor. The word kwashiorkor, from the Ga language of West Africa, means disease of the displaced child because it was commonly seen after weaning. The presence of peripheral edema distinguishes children with kwashiorkor from those with marasmus and nutritional dwarfism. Children with kwashiorkor also have characteristic skin and hair changes, see later. The abdomen is protuberant because of weakened abdominal muscles, intestinal distension, and hepatomegaly, but ascites is rare. The presence of ascites, therefore, should prompt the clinician to search for liver disease or peritonitis. Children with kwashiorkor are typically lethargic and apathetic, but become very irritable when held. Kwashiorkor most often occurs when a physiologic stress, e.g., infection, is superimposed on an already malnourished child. Because infection or other acute stress is usually present in kwashiorkor, the metabolic aberrations associated with secondary PEM are in play, and contractions of the visceral protein compartment are evident. A decrease in serum proteins like albumin is common, distinguishing it from pure marasmus. Kwashiorkor is characterized by leaky cell membranes that permit movement of potassium and other intracellular ions into the extracellular space, causing water movement and edema. Table 5.15 Major cytokines that mediate hypercatabolism and hypermetabolism associated with metabolic stress. Cytokine cell sources. Metabolic effects. IF gamma lymphocytes, pulmonary macrophages, increased monocyte respiratory burst. IL-1 beta monocytes / macrophages, neutrophils, lymphocytes, keratinocytes, Kupffer cells. Increased ACTH and cortisol levels. Increased acute phase protein synthesis. Increased AA release from muscles. Decreased insulin secretion. Fever. IL-6 monocytes / macrophages, keratinocytes, endothelial cells, fibroblasts, T cells, epithelial cells. Increased acute phase protein synthesis. Fever. Decreased appetite. TNF-alpha monocytes / macrophages, lymphocytes, Kupffer cells, glial cells, endothelial cells, natural killer cells, mast cells decreased FFA synthesis, increased lipolysis, increased AA release from muscles, increased hepatic AA uptake, fever AA, amino acid, FFA, free fatty acid, IFN, interferon, IL, interleukin. Adapted from Smith M., Lowry S. The hypercatabolic state. In, Schills M., Olson J., Sheik M., Ross A.C., editors. Modern Nutrition in Health and Disease. Baltimore, Williams and Wilkins, 1999. p. 1555. Table 5.16 Waterlow classification of protein energy malnutrition in children. Parameter: normal, mild, moderate, severe. Weight for height, wasting, percentage of median NCHS standard 90 to 180 to 8970 to 7970. Standard deviation from the NCHS median NZ to Z-1.1 Z to -2 Z-2.1 Z to -3 Z-3 Z. Height for age, stunting, percentage of median NCHS standard 95 to 105 90 to 94 85 to 89 85. Standard deviation from NCHS median NZ to Z-1.1 Z to -2 Z-2.1 Z to -3 Z-3 Z. NCHS, National Center for Health Statistics, Z, standard score. Table 5.17 Features of protein energy malnutrition syndromes in children. Syndrome parameter: kwashiorkor, marasmus, nutritional dwarfism, appetite poor, good edema present, absent mood, irritable when picked up, apathetic when alone, alert. Weight for age, percent expected, 60 to 80 60 weight for height, normal or decreased, markedly decreased. Normal. Chapter 5 Nutritional Principles in Assessment of the Gastroenterology Patient 67 5 Marasmus, weight loss and marked depletion of subcutaneous fat and muscle mass are characteristic features of children with marasmus. Ribs, joints, and facial bones are prominent, and the skin is thin, loose, and lies in folds. In contrast, the visceral protein compartment is relatively spared, a fact that often is reflected by a normal serum albumin level, which in turn sustains normal oncotic pressure in the vascular compartment, thus minimizing edema and helping to distinguish these children from those with kwashiorkor. Nutritional dwarfism: the child with failure to thrive may be of normal weight for height but have short stature and delayed sexual development. Providing appropriate feeding can stimulate catch-up growth and sexual maturation. The diagnosis of PEM is different in adults than in children, because adults do not grow in height. Therefore, undernutrition in adults causes wasting rather than stunting. In addition, although pure forms of kwashiorkor and marasmus can occur in adults, contemporary studies of adult PEM in high-income societies typically focus on hospitalized patients with secondary PEM, coexisting illness or injury, and overlapping features of kwashiorkor and marasmus. Physiologic impairments caused by protein energy malnutrition. PEM adversely affects almost every organ system, although the brain usually is spared. Almost all adverse effects are reversible with nutritional restitution. The following discussion is not exhaustive, rather, it emphasizes impairments that commonly translate into overt morbidity or that are important in the diagnosis of PEM. The effects described reflect what occurs in primary PEM. Superimposition of acute illness and secondary PEM often imposes more complexity. System effects: gastrointestinal tract. Although PEM alone produces adverse effects on GI structure and function, diminished stimulation of the GI tract by a lack of ingested nutrients has an independent effect. Thus, sustained absence of nutrients passing through the intestine of healthy, nutritionally replete, parenterally fed individuals alone results in functional atrophy of the small intestinal mucosa, as evidenced by a loss of brush border enzymes and diminished integrity of the epithelial barrier. Villus atrophy may also be observed with lack of intestinal stimulation, but in the absence of PEM, the degree of structural atrophy is minor. 61 The structural and functional deterioration of the intestinal tract, pancreas, and liver as a result of PEM is described best in children. Marked blunting of the intestinal villi is seen and is usually associated with loss of some or all of the brush border hydrolyses. Gastric and pancreatic secretions are reduced in volume and contain decreased concentrations of acid and digestive enzymes, respectively. The volume of bile and the concentrations of conjugated bile acids in bile are reduced. Increased numbers of facultative and anaerobic bacteria are found in the upper small intestine, probably explaining the increased proportion of free bile acids in the intestinal lumen. Malabsorption of carbohydrates, fats, and fat and water-soluble vitamins may occur, and the degree of steatorrhea is proportional to the severity of the PEM, creating a vicious cycle of further malnutrition. The abdominal protuberance sometimes seen in advanced malnutrition is thought to arise in part from intestinal hypomotility and gas distension. Cardiovascular system. Moderate to severe PEM produces quantitative and qualitative declines in the cardiac muscle. Myocardial mass is diminished, although proportionately less than the loss in body weight. Myofibrillar atrophy, edema, and, less commonly, patchy necrosis and infiltration with chronic inflammatory cells are seen in the myocardium. These structural changes are associated with impaired myocardial performance. A decrease in stroke volume, cardiac output, and maximal work capacity may be observed and are most evident under conditions of increased demand. Such functional impairments are sometimes accompanied by bradycardia and, in conjunction with the factors noted, can lead to low blood pressure. Immune system. The immune system is the most vulnerable to PEM, which explains why several functions of immunity are used diagnostically as indicators of malnutrition, e.g., total lymphocyte count and delayed skin hypersensitivity. The functional integrity of T lymphocytes, polymorphonuclear leukocytes, and complement is uniformly blunted, whereas impaired B lymphocyte production of antibodies is variably affected. A moderately to severely malnourished patient is an immunocompromised individual. Malnutrition leads to increased susceptibility to infection, which in turn promotes development of PEM, so a vicious cycle is created. Respiratory system. The diaphragm and other respiratory muscles undergo structural and functional atrophy, diminishing inspiratory and expiratory pressures and vital capacity. These changes in muscular performance, in conjunction with blunted ventilatory drive, impair the ability to sustain ventilation in the severely malnourished individual. In patients with a tracheostomy, adherence of bacteria to the tracheal epithelium correlates with the severity of PEM, exacerbating other compromises in the immune system described earlier. Endocrine system. Although alterations in hormones are common in PEM, many of the changes can be perceived as serving adaptive functions. The inadequate intake of food leads to a decrease in the availability of circulating glucose and AAS, low circulating levels of insulin, and increased levels of growth hormone. These alterations, in conjunction with the decreased levels of somatomedins and increased levels of cortisol in PEM, promote skeletal muscle catabolism and at the same time enhance incorporation of the liberated AAS into visceral organs. Urea synthesis is inhibited, decreasing nitrogen loss and enhancing reutilization of AAS. Enhancement of lipolysis and gluconeogenesis provides a substrate for energy needs. Serum levels of triiodothyronine, T3, and thyroxine, T4, are commonly decreased in conjunction with increased concentrations of reverse T3, resembling the pattern observed in the euthyroid 6 syndrome. The decreased concentration of T3 may play a role in decreasing Re and the protein catabolic rate observed in primary PEM. Primary gonadal dysfunction is common in adults with moderate to severe PEM and results in impaired reproductive potential. Decreased circulating levels of testosterone in men and estrogen in women is evident, and amenorrhea is common. Delayed puberty or loss of menstrual periods most often occurs when lean body mass drops below a critical threshold. These changes can also be considered physiologic adaptations, because ensuring immediate survival is more critical than the need for sexual maturation in the child or reproduction in the adult. 68 Part 2 Nutrition in Gastroenterology. Other effects. Wound healing. Well-nourished individuals lay down more collagen at the site of a surgical wound than those with even mild malnutrition. Nutritional repletion of the malnourished patient before surgery leads to better wound healing than if nutritional needs are only addressed post-operatively. Skin undernutrition often causes dry, thin, and wrinkled skin, with atrophy of the basal layers of the epidermis and hyperkeratosis. Severe malnutrition may cause considerable depletion of skin protein and collagen. Patients with kwashiorkor experience sequential skin changes in different areas. Hyperpigmentation occurs first, followed by cracking and stripping of superficial layers, leaving behind hypopigmented, thin, and atrophic epidermis that is friable and easily macerated. Scalp hair becomes thin and sparse and is easily pulled out. In contrast, the eyelashes become long and luxuriant, and there may be excessive lanugo in children. The hair of children with kwashiorkor develops hypopigmentation, with reddish-brown, gray, or blonde discoloration. Adults may lose axillary and pubic hair. Kidneys' renal mass and function are often well preserved during undernutrition. When malnutrition is severe, however, there are decreases in kidney weight, glomerular filtration rate, ability to excrete acid and sodium, and ability to concentrate urine. Mild proteinuria also may occur. Bone marrow severe undernutrition suppresses bone marrow red blood cell and white blood cell production, leading to anemia, leukopenia, and lymphocytopenia. Nutritional assessment techniques. The purpose of nutritional assessment is to identify PEM and other nutritional deficits even when they are not readily discernible. PEM can be subtle, but most cases are detected when a systematic nutritional assessment is performed. An example of subtle but clinically significant PEM is found in child Turcotte-Pugh Class A patients with alcoholic cirrhosis. These individuals usually appear well nourished. Indeed, one criterion to determine Class A status is a normal serum albumin level, but studies of whole body nitrogen by in vivo neutron activation analysis have demonstrated that more than half of these Class A individuals have less than 80% of expected total body protein 62, the threshold level below which patients have increased morbidity associated with malnutrition. 63 in otherwise healthy people and in those who are chronically ill. PEM is usually defined by comparing an anthropometric measurement, e.g., weight for height, to established normative standards, see Table 5.6. In contrast, there is no gold standard to define and measure PEM in the acutely ill patient, because most parameters used to assess PEM in otherwise healthy persons are altered by illness. Weight and the concentration of serum proteins are prime examples. Despite the inaccuracies inherent in assessing PEM in acutely ill individuals, the usefulness of nutritional assessment in this setting has been repeatedly demonstrated. Acutely ill patients who are malnourished sustain higher rates of malnutrition-related morbidity. Thus, the presence of PEM has a predictive value. Even more importantly, identifying malnourished patients and then providing appropriate nutritional intervention is likely to improve clinical outcome. 64-68 Meta-analyses have underscored the importance of performing objective nutritional assessments to categorize inpatients, because individuals who are well-nourished or mildly malnourished seem to realize little benefit from intensive nutritional support. 69-71 A comprehensive nutritional assessment requires a history, physical examination, evaluation of anthropometrics or functional measures of nutritional status, and a panel of laboratory blood tests. Some of the more commonly used assessment tools are weight, height, and other anthropometric measures, e.g., skin fold thickness and mid-arm measurements, functional measures, e.g., hand grip strength or skin testing for evidence of anergy, serum protein concentrations, e.g., albumin or prealbumin, complete blood count, including absolute lymphocyte count, and 24-hour urinary creatinine and blood urea nitrogen levels. Less readily available measures of body composition, such as bioelectrical impedance and total body potassium, can be helpful in the appropriate setting. Some of these measures lack a high degree of specificity but continue to be useful in clinical care because of their prognostic significance. Because no single parameter is sufficiently sensitive or specific to assess PEM, these tools are most effective when used in combination. Importantly, if the clinician is undertaking a nutritional assessment solely to determine whether a patient falls into a category of moderate to severe PEM, and thus one who would benefit from intensive nutritional support, far less than comprehensive assessment will usually suffice. Such simple means of categorization are provided in the following sections. History: weight loss, how much weight has been lost and over what time period. Unintentional weight loss associated with illness is the single most practical predictor of a clinically significant degree of PEM. It is useful to quantify such loss by determining whether the patient has sustained a mild, 5%, moderate, 5% to 10%, or severe, 10%, degree of loss over the preceding 6 months. Because acute illness incites a disproportionately large loss of lean mass, it is not surprising that a greater than 10% unintentional loss in body weight usually correlates with a 15% to 20% decrease in total body protein. 63 This degree of unintentional loss is an important threshold because it is associated with impaired physiology, a poor clinical outcome, and extended hospitalization. 72-74. It also defines those individuals who will likely benefit from intensive nutritional support. The clinician should nevertheless be mindful that determining the magnitude of weight loss by history has limited accuracy. One study found that 1/3 of patients with true weight loss go undetected by history, and 1/4 of those who had been weight stable are miscategorized as having undergone weight loss. 75 Furthermore, the nutritional significance of changes in body weight can be confounded by changes in hydration status and extracellular fluid accumulation. Because weight loss is an imperfect indicator of PEM, it is useful to obtain other historical clues that can contribute to the identification of these patients. See later. Food intake. Has there been a change in habitual diet pattern, number, size, and contents of meals? What is the reason for altered food intake, e.g., change in appetite, mental status or mood, ability to prepare meals, ability to chew or swallow, GI symptoms? Evidence of malabsorption. Are there signs, symptoms, or both consistent with malabsorption? Chapter 5 Nutritional Principles and Assessment of the Gastroenterology Patient. 69 5 Evidence of specific nutrient deficiencies. Are there signs, symptoms, or both of specific nutrient deficiencies, including macrominerals, micronutrients, and water? See Tables 5.9 to 5.11. Influence of disease on nutrient requirements. Is the nature of the patient's underlying illness one that is likely to increase nutrient needs or nutrient losses? Functional status. Has the patient's ability to perform daily activities that determine consumption of wholesome meals changed? Can the patient still shop and prepare meals? Have finances interfered with the ability of the patient to purchase food? Physical examination. Hydration status. The patient should be evaluated for signs of dehydration, e.g., hypotension, tachycardia, postural changes in blood pressure and pulse, mucosal cirrhosis, decreased axillary sweat, dry skin, and excess body fluid, e.g., edema or ascites. Tissue depletion. A general loss of adipose tissue can be assumed if there are well-defined bony, muscular, and venous outlines and loose skin folds. A fold of skin pinched between the forefinger and thumb can reveal the adequacy of subcutaneous fat. The presence of hollowness in the cheeks, buttocks, and perianal area suggests body fat loss. Examination of the temporalis, interosseous, and quadriceps muscles should be done to judge muscle wasting. Muscle function strength testing of individual muscle groups can be performed to determine if there is generalized or localized muscle weakness. Myocardial function can be evaluated, and respiratory muscle function can be assessed with spirometry. Specific nutrient deficiencies. Rapidly proliferating tissues, e.g., oral mucosa, hair, skin, GI epithelium, bone marrow, are often more sensitive to nutrient deficiencies than tissues that turn over more slowly, e.g., heart, skeletal muscle, brain. See Tables 5.9 to 5.11. Anthropometry. Anthropometric techniques are those in which a quantitative measure of the size, weight, or volume of a body part is used to assess protein and calorie status. Historically, one of the most commonly used anthropometric parameters has been weight for height. This is a useful parameter when neither the patient nor family can provide reliable historical information, but it is less desirable than a history of unintentional weight loss, because it requires the patient's weight to be judged against a normative standard that has been established in a large control population, and inter-individual variability in the population limits this method's accuracy for correctly predicting PEM in one individual. Table 5.6 displays the 1959 Metropolitan Life Insurance Company desirable body weights that were established with prospective mortality data. The 1959 table remains preferable to the 1983 tables largely because of concerns that the latter did not include an adequate sampling of certain segments of the population, and was therefore biased. In the context of the Metropolitan Table, desirable weight for height is defined as that figure associated with maximal longevity. In general, individuals whose weight is less than 85% of the standard can be considered to have a clinically significant degree of PEM. Of note is that desirable weights in this table are substantially less than average weights in North America. Body Mass Index, Table 5.18, defined as weight, in kilograms, divided by height, in meters squared, has been supplanting the use of weight for height, in part because it precludes the need to use normative data tables. BMIs outside the desirable range, 18.5 to 24.9 kg/m2, help identify patients at increased risk of adverse clinical outcomes. A BMI modestly above the desirable range has been shown to be predictive of adverse outcomes in the surgical management of many diseases 76-78 and in the medical management of conditions like alcoholic liver disease. 79 Similarly, a low BMI has been shown to be a robust independent risk factor in surgical and medical patients. 80 Extremely underweight adult patients, BMI 14 kg/m2, are at high risk of death and should be strongly considered for admission to the hospital to initiate intensive nutritional support. The BMI, like weight for height, is a surrogate and imperfect measure of body composition. A low BMI, 18.5 kg/m2, is interpreted as an indication of PEM, and a high BMI, greater than 24.9 kg/m2, is interpreted as excessive fat mass, overweight or obesity. Although BMI is accurate in this regard for the vast majority of adults, it can be just as misleading as other measures that rely on body weight without a direct evaluation of body composition. 81 For example, the individual with excessive fluid accumulation, where actual fat and body cell mass, BCM, are less than that implied by the BMI, and the muscle-bound athlete, where a high BMI is indicative of an extraordinarily large lean mass, are two examples of how the underlying assumptions inherent in the BMI are false. Sex and race are also confounding variables, although the differences are clinically irrelevant. More important are the remarkable changes in body composition that accompany development, making the interpretation of BMI in childhood and adolescence very complex. 82 It should be apparent from this discussion that measurements of relevant body compartments, e.g., fat mass or fat-free mass FFM, can reveal important information about nutritional status that is often obscured by measurement of weight alone. Underwater, hydrostatic, weighing, dual energy X-ray absorptiometry, air impedance plethysmography, total body potassium, isotopically labeled water dilution, in vivo neutron activation analysis, computed tomography and magnetic resonance imaging are accurate non-invasive, or minimally invasive, techniques of measuring body compartments. 82-89 All are highly effective, but because of their expense, lack of accessibility, and impracticality, their use is largely relegated to the sphere of clinical research. A detailed understanding of these tools is beyond the scope of this chapter, but the primary use of each, with reference to detailed reviews, is outlined in Table 5.19. In the clinical setting, simple but less accurate techniques are used to assess body compartments. An approximate measure of Table 5.18 classification of nutritional status by body mass index in adults. Body mass index, kg/m2, nutritional status 16.0, severely malnourished 16.0 to 16.9, moderately malnourished 17.0 to 18.4, mildly malnourished 18.5 to 24.9, normal 25.0 to 29.9, overweight 30.0 to 34.9, obese, Class I, 35.0 to 39.9, obese, Class II, greater than or equal to 40, obese, Class III, 70. Part 2 Nutrition in gastroenterology. Whole body fat mass can be derived from assessing the thickness of subcutaneous fat, which in a normally proportioned adult contains roughly half of the body's adipose stores. The triceps and subscapular sites are used most commonly for this purpose, and it is best to use the sum of the triceps and subscapular folds because sizable inter-individual differences exist in fat distribution. Furthermore, as total body fat changes, the subcutaneous fat at each site responds in a different manner. Similarly, mid-arm muscle circumference, MAMC, provides a measure of skeletal muscle mass. Table 5.20 contains guidelines for interpretation of skin fold and mid-arm muscle area based on data from the first two National Health and Nutrition Examination Surveys, NHANES I and II. 0.90 Clinical use of skin folds and appendicular muscle area has distinct weaknesses. As was true for the weight for height tables, there is considerable inter-individual variation in values, so these measurements are more useful in population studies than in an individual. Moreover, these measures are highly operator-dependent. 91 Also, although the updated databases defining normative values no longer contain the race and age biases of older versions, correction factors for hydration and physical activity are still unavailable. In practice, we have found the most useful clinical role for the measurement of skin folds and muscle area is in tracking patients with serial measurements over time as a means of monitoring their recovery from disease or response to a clinical intervention. In this manner, the patient is being compared with himself or herself rather than with some normative value. In gastroenterology, the use of skin folds and muscle area has been of particular value in the assessment and management of cirrhotic patients, because cirrhosis corrupts almost all the other common measures of nutritional status. Abnormally low values for triceps skin fold and MAMC are independent predictors of mortality in patients with cirrhosis, and their incorporation into a Cox regression model improves the prognostic value of the Child-Turcotte score. 92 Also, when patients with severe alcoholic hepatitis are treated with anabolic steroids, improvements in MAMC and other measures of the FFM correlate with a positive response to treatment. 93 Interest continues in bioimpedance analysis as an inexpensive, relatively easy, non-invasive, and safe means of assessing FFM, BCM, and total body water. BCM is sometimes perceived as a more important measure of lean mass than FFM because it does not include non-living lean mass, e.g., blood plasma and bone minerals. See Fig. 5.1. Resistance to electrical flow through the body is measured, which is proportional to fat and bone mineral content because these body components have poor conductivity. Because all other components of the body are suffused with electrolyte-laden water that readily conducts an electric current, calculations of total body water, FFM, and BCM can be made if one abides by some general assumptions that define the water content of each compartment. Those with expertise in its use have found it useful for monitoring the FFM in outpatient studies of renal dialysis and HIV-infected patients. 94. 95 Acute illness, however, produces shifts in the total amount of body water and its distribution, rendering the technique largely worthless in the inpatient setting. 96 Furthermore, the algorithms used to calculate body composition contain assumptions about body water that can change with age, obesity, and disease, so bioimpedance analysis must be revalidated within any population in which it is used. Functional measures of protein calorie status. Several techniques have been developed that exploit the fact that skeletal muscle function is impaired in PEM, although only one has acquired wide acceptance: fist grip dynamometry, FGD. FGD uses a handheld dynamometer to measure the maximal fist grip force that can be elicited. When examined as a surrogate measure of total body protein in patients awaiting GI surgery, FGD correlated strongly with in vivo neutron activation analysis and with MAMC. 97 Similarly, FGD is excellent for detecting depleted BCM in cirrhotic patients. 98 A group in which it is notoriously difficult to perform nutritional assessment. As noted, valid indicators of moderate to severe PEM are strong predictors of clinical outcome in acutely ill patients, and FGD is effective in this regard. Preoperative patients whose fist grip strength is less than 85% of age and sex-corrected standards have a twofold increased risk of Table 5.19 Advanced techniques for measurement of body compartments. Technique primary use in body compartment analysis: air displacement plethysmography. 91 Proportion of body composed of FM, proportion of body composed of LM. CT 90 Regional FM/LM dual energy X-ray absorptiometry. 92 Absolute FM and LM, bone density in vivo neutron activation analysis. 95 Total body protein, absolute FM, absolute LM isotopically labeled water and NABR dilution. 94 TBW, ICW, ECW MRI 96 Regional FM/LM Total body potassium 93 Body cell mass underwater, hydrostatic, weighing 89 Proportion of body composed of FM, proportion of body composed of LM ECW, extracellular water, FM, fat mass, ICW, intracellular water, LM, lean mass, NABR, sodium bromide, TBW, total body water. Table 5.20 Normative standards for upper arm muscle area and sum of triceps and subscapular skin folds parameter age percentile 5th 50th 85th upper arm muscle area, cm2, asterisk men 25 to 29 38 53 65 45 to 49 37 55 66 65 to 69 33 48 63 women 25 to 29 20 30 38 45 to 49 21 32 45 65 to 69 22 35 46 sum of triceps and subscapular skin folds, mm, men 25 to 29 12 24 41 45 to 49 13 29 43 65 to 69 12 27 42 women 25 to 29 18 37 58 45 to 49 21 46 68 65 to 69 22 45 65 asterisk mid. Upper arm muscle area, cm2, is calculated as follows: for men, area equals arm circumference, pi times triceps skin fold 2 4 pi, 10 for women, area equals arm circumference pi times triceps skin fold 2 4 pi 6.5 adapted with permission from Fries & Co. AR anthropometric standards for the assessment of growth and nutritional status. Ann Arbor, Mitch, University of Michigan Press, 1990. Chapter 5 Nutritional Principles and Assessment of the Gastroenterology Patient 71 5 Perioperative complications compared with those whose FGD is normal. 99 In patients undergoing surgery for GI cancers, FGD had superior sensitivity and specificity in predicting perioperative morbidity and mortality than a widely used discriminate analysis called the Prognostic Nutritional Index. 100 FGD holds considerable promise for rapid and convenient assessment of protein calorie status in both inpatients and outpatients, but the technique is limited by its requirement for an alert and cooperative patient. Respiratory muscle strength, typically measured with a bedside spirometer as maximal sustained inspiratory force, maximal sustained expiratory force, or both, has also been used as a measure of protein calorie status but is generally considered unreliable because too many non-nutritional factors may alter its measurement. Although PEM adversely affects the physiology of almost all organ systems, the immune system is the most sensitive. Delayed hypersensitivity skin testing, which assesses the integrity of cell-mediated immunity, has been used most often in this regard. In critically ill patients, skin testing has value in predicting morbidity and mortality, but its interpretation is fraught with confounding variables such as older age, systemic infection, and major surgery, each of which will independently depress reactivity. Furthermore, reactivity improves in an unpredictable manner with nutritional restitution, so it is not useful for monitoring patient progress. 101 The value of skin testing to assess nutritional status is used best as part of an array of parameters that collectively assess nutritional status. See later, discriminate analyses of protein calorie status. Biochemical measures of protein calorie status. Serum proteins. The serum concentrations of several proteins synthesized in the liver are used as indicators of protein calorie status: albumin, prealbumin, transthyretin, transferrin, and retinol-binding protein, RBP, Table 5.21. In the absence of concurrent illness or injury, a low concentration of any of these proteins strongly suggests the presence of PEM. Because the half-lives of prealbumin, transferrin, and RBP are considerably shorter than that of albumin, it follows that changes in nutritional status will be reflected more promptly in levels of these three proteins than in albumin. A variety of factors alters the serum concentration of each of these proteins. Prealbumin levels are often elevated in chronic kidney disease or by glucocorticoid or oral contraceptive administration. The degree to which serum levels of all these proteins are decreased in cirrhosis increases incrementally with worsening grades of the child classification, although even patients who are child class A have a small decrease in albumin compared with healthy individuals. 102 All these proteins behave as negative acute phase reactants, i.e., their serum concentrations drop in response to systemic inflammation, roughly proportional to the magnitude of the inflammatory response. This effect diminishes their reliability as indicators of PEM in the acutely ill patient, particularly when used as a sole metric of nutritional status. Nonetheless, with proper respect for their limited accuracy, they can still be useful. For example, prealbumin has been shown to be an efficient rapid means of screening in patients for PEM on hospital admission. 103 Creatinine height index. The amount of creatinine excreted in the urine over a 24-hour period, corrected for the patient's height, is an excellent means of assessing total skeletal muscle mass. The relationship holds because a relatively constant percentage, 2%, of muscle creatine is converted to creatinine each day. Values that are greater than 20% below sex and height-adjusted normative values are indicative of moderate to severe PEM, Table 5.22. Updated normative creatinine height index, CHI, values for children of ages 3 to 18 years are available. 104 In sick persons, the CHI tends to correlate with simple measures like unintentional weight loss, as well as with highly accurate measures of skeletal muscle like dual energy X-ray absorptiometry. 105 In patients receiving prolonged mechanical ventilation, CHI is a strong independent risk factor concurring with the likelihood of successful weaning and survival. 106 To avoid misleading results, potential confounders that must be considered include incomplete urine collection, abnormal or unstable renal function, excessive meat or milk ingestion immediately preceding or during the collection, and glucocorticoid administration, all of which can alter creatinine excretion independently of changes in muscle mass. Table 5.21 Proteins synthesized in the liver and used to assess nutritional status. Serum protein normal value mean plus or minus SD, range, asterisk half-life, days, function comment albumin 4.5, 3.5 to 5.0, 14 to 20 maintains plasma oncotic pressure, carrier for small molecules. Serum levels altered by a variety of non-nutritional factors. Transferrin 2.3, 2.0 to 3.2, 8 to 9 binds Fe2+ in plasma and transports it to bone marrow. Iron Nutritor influences plasma level, increased during pregnancy, estrogen therapy. An acute hepatitis, reduced in protein-losing enteropathy and nephropathy, chronic infections, uremia, and acute catabolic states, often is measured indirectly as total iron binding capacity. Transthyretin, prealbumin, 0.30, 0.2 to 0.5, 2 to 3 binds T3 and to a lesser extent T4, is a carrier for RBP increased by corticosteroid, glucocorticoid, or oral contraceptive administration, in those with chronic kidney disease on dialysis, reduced in acute catabolic states, after surgery. In hyperthyroidism, serum level is determined by overall energy and nitrogen balance. Retinol binding protein, RBP, 0.0372 plus or minus 0.0073. 0.5 transports vitamin A in plasma, binds noncovalently to prealbumin catabolized in the renal proximal tubular cell. With renal disease, RBP increases and its half-life is prolonged. Low plasma levels in vitamin A deficiency, acute catabolic states, after surgery, and in hyperthyroidism. * units are G/L. Normal range varies among centers. Check local values. All the listed proteins are influenced by hydration and presence of hepatocellular dysfunction. Normal values are age and sex dependent. Table value is for pooled subjects. SD, standard deviation, T3, triiodothyronine, T4, thyroxine. Adapted from Hamesfield S., Ty A., Wang's EM Nutritional Assessment by Anthropometric and Biochemical Means. In, Schills M., Olson J., Sheik M., Editors. Modern Nutrition in Health and Disease. 8th ed. Philadelphia, Lee and Fabiger, 1994. p. 812. 72 Part 2 Nutrition in Gastroenterology. Discriminate analyses of protein calorie status as noted, many parameters used to measure PEM can also predict important clinical outcomes, although each parameter has its own limitations. Multifactorial indices that incorporate various combinations of these parameters have been developed through the use of discriminate analyses. By combining the strengths of several parameters, the goal has been to arrive at a more accurate determination of whether a patient has a substantial degree of PEM and to optimize the ability to predict which patients will have adverse clinical outcomes because of PEM. Over the past several decades, various indices have been developed for use in acutely hospitalized patients, for instance, the Prognostic Nutritional Index, which incorporates serum albumin, transferrin, delayed skin hypersensitivity, and triceps skin fold, predicts the likelihood of postoperative complications and mortality in patients undergoing GI surgery. 107, the Geriatric Nutritional Risk Index, which incorporates serum albumin and percent IBW, predicts the likelihood of infectious complications and mortality among elderly inpatients. 108 Since readily available metrics of PEM in the acute care setting are so heavily influenced by disease severity, these indices should not be considered as accurate measures of the degree of malnutrition. More properly, they are best considered predictors of morbid and mortal events that are known complications of PEM. Two more recent additions to this list of indices for the acute care setting are the Nutrition Risk Score 2002 and the Nutric Score. 109 As is true of the older indices, their use has been designed and validated for a specific type of patient, namely, ICU patients. A significant advance accompanying the introduction of the NRS 2002 and Nutric is the studies that have explored whether these indices can discriminate those patients who genuinely benefit from intensive nutritional support from those who will not. 110-112 Rapid screening tools for assessment of targeted populations. Assessing nutritional status with inexpensive, rapid, and convenient means that are accurate in identifying patients with PEM is of great value, particularly when large numbers of people need to be evaluated. Two such tools have been developed and extensively validated: the Subjective Global Assessment, SGA, and the Mini-Nutritional Assessment, MNA. Subjective Global Assessment (SGA) was initially intended for use in surgical inpatients as a means of assessing nutritional status and predicting postoperative infections, Box 5.1. For the latter, it was found to be a better predictor. Table 5.22 Normative values for daily creatinine excretion based on height. Men * women height, cm, ideal creatinine, mg, height, cm, ideal creatinine, mg, 157.5 1288 147.3 830 160.0 1325 149.9 851 162.6 1359 152.4 875 165.1 1386 154.9 900 167.6 1426 157.5 925 170.2 1467 160.0 949 172.7 1513 162.6 977 175.3 1555 165.1 1006 177.8 1596 167.6 1044 180.3 1642 170.2 1076 182.9 1691 172.7 1109 185.4 1739 175.3 1141 188.0 1785 177.8 1174 190.5 1831 180.3 1206 193.0 1891 182.9 1240 Creatinine coefficient, men, equals 23 mg/kg of ideal body weight. Creatinine coefficient, women, equals 18 mg/kg of ideal body weight. From Blackburn GL, BIS Tirian BR, Maney BS, ETAL Nutritional and Metabolic Assessment of the Hospitalized Patient. J. Parente or Enteral Nutr 1977, 1:11-22. Box 5-1 Subjective Global Assessment of Nutritional Status History Weight Change, Loss in Past 6 months, Amount equals _____________________________________________________________ Percent loss equals __________________ change in past 2 weeks, increase no change decrease dietary intake change. No change 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 duration equals weeks dietary status suboptimal solid diet hypocaloric liquids starvation gastrointestinal symptoms that have persisted for greater than 2 weeks none nausea vomiting diarrhea anorexia functional capacity no dysfunction dysfunction duration equals weeks type working suboptimally ambulatory but not working bedridden effect of disease on nutritional requirements primary diagnosis metabolic demand low stress moderate stress high stress physical examination normal moderate or severe loss of subcutaneous fat triceps chest muscle wasting quadriceps deltoids ankle or sacral edema ascites SGA rating *A equals well nourished B equals mild or moderate malnutrition C equals severe malnutrition *. The ranks of A, B, and C in the SGA are assigned on the basis of subjective weighting. A patient with weight loss and muscle wasting who is currently eating well and gaining weight is classified as well nourished. A patient with moderate weight loss, between 5% and 10%, continued compromise in food intake, continued weight loss, progressive functional impairment, and moderate stress due to illness is classified as moderately malnourished. A patient with severe weight loss, 10%, poor nutrient intake, progressive functional impairment, and muscle wasting is usually classified as having severe malnutrition. Chapter 5 Nutritional Principles in Assessment of the Gastroenterology Patient 73.5 Then serum albumin concentration, delayed skin hypersensitivity, MAMC, CHI, and the prognostic nutritional index. 113. A focused history and physical examination are used to categorize patients as well-nourished. Category A, having mild or moderate malnutrition. Category B, or having severe malnutrition. Category C. Despite the subjective nature of some of its components, there is excellent agreement among independent observers. 114. The SGA has been shown to be reliable, even in the hands of first-year medical and surgical residents. 115. And has been validated as a predictor of clinical outcomes in chronically institutionalized older adults and patients with a variety of medical conditions. 116-118. Mini nutritional assessment. The MNA was developed as a rapidly administered screen to detect PEM in geriatric populations. A combination of history, limited physical examination, and simple anthropometrics, BMI, arm, and calf circumference, can be obtained in a few minutes. Subjects receive a score that classifies them as being nourished, malnourished, or at risk of malnutrition. The MNA is a valid means of detecting PEM in older adults who are generally healthy and ambulatory, as well as those who are frail and institutionalized. 119-120. In the chronically institutionalized, it possesses considerable predictive value in projecting future morbidity. 121. One disadvantage of the MNA is that it does not screen for overweight or obesity. Other screening tools designed for geriatric populations, such as the Nutrition Screening Initiative, have the ability to screen for under and overnutrition but have not been as extensively validated as the MNA. 122. Aggressive nutritional support in the hospitalized patient. The chapter that follows provides detailed descriptions of the approaches to nutritional management that are presently accepted as appropriate in the setting of specific GI and hepatic diseases. As a means of introduction, however, it is first worth considering under what circumstances clinical observations indicate that aggressive nutritional support, defined as using whatever means necessary and practical to meet the patient's nutritional needs, truly benefits the acutely ill patient. In practice, any acutely ill patient who has moderate to severe malnutrition and is unlikely to be able to meet his or her own nutritional needs within 48 hours is a strong candidate for aggressive nutritional support. Another common indication for aggressive nutritional support is when a well-nourished or mildly malnourished inpatient is judged to be unlikely to meet at least 80% of his or her projected calorie or protein goals for the coming 10 days. To date, there is insufficient evidence-based science to prove efficacy of this latter indication, although common sense would suggest it to be true. Catabolic forces that accompany acute illness make it difficult to correct nutritional deficits. In those with a high degree of sustained metabolic stress, nutritional support generally will not lead to an increase in the protein compartment of the body. Moreover, a gain in weight may not occur, and when it does, much of the initial gain is from water and an expanded fat mass. 123. Despite these limitations, even in the absence of weight gain or increases in serum protein levels, a course of nutritional support for an appropriate patient can improve physiologic functions and clinical outcomes. 124. The following three sections cite some clinical scenarios particularly relevant to gastroenterology for which compelling clinical research upholds that aggressive nutritional support provides benefit to the hospitalized patient. Malnourished patients undergoing major surgery. Nutritional support can be beneficial for moderately to severely malnourished patients who are scheduled to undergo major surgery. Aggressive nutritional support for 7 or more days before surgery reduces perioperative complications and sometimes mortality in malnourished patients. 64-71, 125-127 in the Veterans Affairs TPN Cooperative Study 64, which encompassed almost 500 subjects about to undergo major abdominal or thoracic surgery, patients who were categorized as severely malnourished and randomized to receive preoperative TPN realized an almost 90% decrease in non-infectious perioperative complications. No benefits were observed in mildly malnourished or well-nourished individuals. In trials of moderately to severely malnourished patients, preoperative nutrition support generally conveys sizable benefits, a trial that enrolled 90 patients with gastric or colorectal cancers undergoing surgery demonstrated a 35% decline in overall complications and a significant reduction in mortality. 127 The observation that the benefits of preoperative nutritional support are confined to those with a substantial degree of malnutrition is the same conclusion reached by meta-analyses. 69 70 Deferring aggressive nutritional support until after surgery does not appear to have the same ability to diminish perioperative complications. 128 Provision of nutrients via an enteral approach is also beneficial. There have been fewer trials done of preoperative enteral support than of preoperative TPN, but it appears that preoperative enteral support confers the same nutritional 129 and clinical 130 benefits as TPN. As with TPN, postoperative enteral nutrition in the absence of aggressive preoperative support is less likely to convey benefit to the patient. 131 Patients hospitalized with decompensated alcohol-associated liver disease. The prevalence of moderate to severe PEM is so high in patients admitted for acute alcoholic hepatitis and other forms of decompensated alcoholic liver disease 62 that it is best to assume all such patients are malnourished. Furthermore, patients with acute alcoholic hepatitis usually fall far short of their nutritional needs when allowed to eat freely. Clinical trials have demonstrated that the rates of morbidity, mortality, and the speed of recovery are improved with prompt institution of enteral or parenteral nutrition in these patients. 65-67 132 patients undergoing radiation therapy. The usefulness of aggressive nutrition support in patients undergoing radiation therapy has been studied most extensively in those who have head and neck and esophageal cancers. There is now reasonable evidence in these patients that placement of a PEG tube and administration of supplemental tube feedings during and after the course of radiation therapy prevents further deterioration of nutritional status. 133-134 In patients with head and neck cancers, supplemental PEG feedings have also been shown to improve quality of life. Although improvements in survival or decreased morbidity have not yet been demonstrated, improved quality of life alone may warrant its use in this setting.